She completed a residency and master's degree in comparative ophthalmology at the University of Wisconsin in 2010. Dr. Myrna has been teaching at the University of Georgia since the completion of her residency. She has been recognized for her teaching and engaging lecture style through the Zoetis Distinguished Teaching Award, multiple student teaching awards, and a Lilly Teaching Fellowship. In 2020, she received the BMX Speaker of the Year Award for Small Animal. Dr. Myrna is going to go about an hour and a half with the corneal ulcers, and we'll take a longer break, and then we'll have one more shorter break this time. Would you please help me welcome Dr. Myrna?
Good morning, everyone. Looks like my mic is out of battery, which seems right to start the day. Thanks for coming out so early and on the last day, no less. We're going to start today talking about corneal ulcers. If there's anything you want to ask, may as well just raise your hand. Got a nice group here, and I can cater to what you're most interested in. We can do cases that match what you've been seeing out in the world. Because what you have for ophthalmologists, you've got in Iowa and Dr. Grajdanek, or do you have anyone in South Dakota? I didn't think so. Yeah, so this is about, my focus is on when the client can't go for referral and how we can manage. So I am a member of the advisory board for Centrix, which makes Oculenus lubricating drops, but I won't be shilling for them. Much to their dismay, it turns out. I think they thought I would be all about it. The screen here is just terrible. So apologize if you can't read the words. They will be captured on the Zoom, and everything's in your notes. So I think we all feel comfortable recognizing a corneal ulcer. You put your stain on, you flush it, the stain doesn't go away. Okay. So I have a three-part approach to corneal ulcers. You have to ask yourself first, and most importantly, is it superficial or deep? The way I'm defining superficial is that it's just a loss of corneal epithelium. So no stromal loss, no depression whatsoever. Looks like a peeled grape. And then we say to ourselves, is it infected or uninfected? The vast majority of infected ulcers will be deep. So in a way, it's a little bit redundant, but it's good to ask yourself that directly. And then, is there any underlying condition that's contributing to the presence of the ulcer or the inability to heal? Okay. So how do we know deep or superficial? This is easy for me because this is all I do all day long. It's the biggest question you have to ask yourself. It's best seen with the slit beam, but no one has a good slit beam. So what I like is to sort of picture the curvature of the cornea, and are there any divots or flattened sections? And it can be as mild as the depression you have on a golf ball, or it could be as severe as looking like someone took an ice cream scooper to it. If you still feel uncertain, I've been doing this for 3 years now and it hasn't hurt me. I will give you my phone number. If you, I know, right? If you take a photo, you can send it to me. You are not getting a 45-minute consultation, but you will get a thumbs up, that is superficial. Thumbs down, don't touch that. Everything is going bad. So my phone number, if you want it, it's my personal cell, is 706-247-3701. After I gave it out at VMX, I figured it was game over anyway because people are emailing it to each other. Right now, I get 2 texts a month. So people are very respectful. And y'all are Midwest nice, so I'm going to say you're going to be respectful as well. All right. If there is stromal loss, there should be some sort of divot. Where it gets confusing is if you have a bunch of blood vessels or sort of mounted up corneal epithelium, it can create a ring around it, which makes it look sort of elevated. But the way I think about it is really thinking about that curve. Okay, all right, so which one is deep? It's okay, you can participate. Left, yes. So it is small, but it looks like someone took a millimolar to it. It is deep. The one on the right is bigger, but it's smooth and even. Okay. The next question we have to ask ourselves is it infected or not? Knowing that if it appears deep, we're going to treat it like it's infected. So what are signs of infection? Infiltrate, so pus, white cells that have migrated into the cornea like a little yellow patch where the ulcer is. Corneal edema, the more edema there is, the more likely it is to be infected. That's pretty non-specific, but in general, uninfected ulcers should only have edema right where the ulcer is. Uveitis, so inflammation inside the eye in response to the disease on the surface of the eye. So you look over here, this doesn't necessarily look that bad from the front, but if you look down at the bottom, I'm not supposed to touch this because, what does it say? Severe damage. And I don't know if that plaque means I will receive severe damage or the screen will, but either way, I'm staying out of it. There's a little bit of pus in the anterior chamber, which is hypopion. It's admixed with a little hyphema, which is blood. So that tells me the body is trying to pull white cells to the ulcer. That does not mean the infection has gone inside the eye, right? So if you have an infected ulcer, it sends the chemoattractants out. It's like, white cells, come to me. And the helpful ones come from the limbus through the cornea to the center. The unhelpful ones come out of the iris across the blood aqueous barrier, and then they just sink down to the bottom of the anterior chamber. So thanks a lot. Like when I asked my brother for help, and I'm like, you're basically the white cell in the anterior chamber. He doesn't know what it means, but to me, that is very cut. Okay. The smaller the pupil is, the more inflamed the eye will be. These things can help you. Okay. They also tend to be more painful. That's also highly breed dependent. You look at a husky sideways, they're squinting, rolling, screaming. And there are Labradors with disgusting melting ulcers. They're wagging their tails, happy as can be. So the dorsal one, although it's much larger and looks kind of scary with all these blood vessels in, the rest of the cornea is nice and clear. It's not infected. Down at the bottom, this is a little bit mushy in the middle, and there's that hypopion. He's been pharmacologically dilated, which sort of ruins my point, but I am in academia. So by the time I get to the eye, they've been through like 4 different people. So all my photos are stained and dilated. Okay. So what do we do when it's simple? My dog went to the dog park, came back squinting. You stain him, he's got fluorescein positive. There's no reason to ring the alarm bells here. So what am I going to do? Some sort of broad spectrum antibiotic that covers gram-positive, cocci, and gram-negative. It's sort of what triple was made for. So I really love triple. An early generation fluoroquinolone can suffice if you don't have triple on the shelf. So neopolygram drops, neopolybac ointment, ofloxacin, ciprofloxacin, and it's just 2 to 3 times a day to prevent a problem. Remind yourself that eye drops do not help the eye to heal when it comes to ulcers, which kind of is like, what am I doing in the world? We actually slow healing, if anything, with eye drops, and that just hurts me to my soul. I was speaking in Spain, And they were like, if it doesn't help it heal and they're not infected, why are you giving antibiotics at all? And I was like, ooh, because I'm American and we get sued, and everyone just laughed. So I went with it. In human medicine, they're actually moving away from doing prophylactic antibiotics on superficial ulcers, but also humans don't lick their butts. Most don't lick their butts. So I feel like they have a different population and different concerns. Okay, atropine. I used to get it fairly regularly, then it became hard to get and it was expensive. The idea of atropine is that the corneal ulcer on the surface of the eye triggers the release of substance P, prostaglandins in the anterior chamber that makes your pupil small because the sphincter starts to spasm, and that is painful. So if we can paralyze the pupillary sphincter and relax that Charlie horse inside the eye, it makes them feel better. So atropine is for pain. In my experience these days, if you just give them a drop in-house and charge them for it, that's usually all they need. So it reduces the number of medications they have to get at home. It increases compliance. You can charge $5 a drop, so you won't lose money on it. So that's what we're doing at the University of Georgia. It doesn't help that our university pharmacy markup makes a bottle of atropine like $65. So that's just a no-go in my book. A normal uninfected corneal ulcer should heal in 3 to 5 days, period. 1 week max. If they come back in a week and they're not healed, you need to go back to the beginning and ask yourself, is it superficial or deep? Is it infected or not? Is there an underlying condition that's keeping it from healing? What about e-collars? Obviously works better for some dogs than others. I'm not a hard liner with e-collars unless they are obviously going to town on their face at the first visit. I'm a realist, and I'm also a bad dog mom. And everything I prescribe for my own pets, from my own pen, I know that I only follow about 50% of my own instructions. So I picture every client as me. So the thing too about e-collars for eye disease is it has to be the rigid e-collars. So the donuts, not helpful. They can just rub their head on whatever they want. The soft ones, again, they can just smush it into their face and rub. My favorite dog though had a perfectly fitted rigid e-collar and put it over the toilet bowl so he could rub his eye on the toilet bowl rim. So you can't fix everyone. Okay. So e-collar first round, that's a plus or minus for me. At a week, if it's not healed, you're getting one. Okay, so why might an ulcer not heal if it's not infected? Okay, the big one is dry eye. And anyone who's got sort of poor tears or low tears is going to have a harder time healing. There's no blood vessels to the corneal surface. It gets the majority of its nutrition from the tear film. And this is relatively straightforward if you have a low Schirmer tear test. What we find with ulcers is that the reflex pain increases tearing. So even if you do a Schirmer tear test on a dog with an ulcer, it might come back normal when it should be elevated, if that makes sense. The other thing, which is much more amorphous, is this concept of a qualitative tear film abnormality. So I'm making lots of the watery part of the tears, but without the right balance of mucus and oil, the tears won't stick to the surface of my eye or they evaporate too quickly. So super common in women, particularly postmenopausal women. I have it right now. It's very frustrating. I think of myself as a little Shih Tzu. Well, correct that, and enormous Shih Tzu with serious tear problems. So the key to finding qualitative tear film abnormalities is that the eye, despite a normal to high Sherber tear test, appears objectively dry, or there's blood vessels on the dorsal half, or if you're in Georgia, there are Shih Tzu. And they pretty much all have qualitative tear films. The real test for this is a tear film breakup time. It is very subjective, and I pretty much never do it myself. I just intuit it. Why else could this beautiful specimen of pugdom have an ulcer that won't heal? Do they blink completely? A lot of dogs, brachycephalics in particular, they'll blink and leave a millimeter open in the middle. Fancy word for that is lag ophthalmos. If they don't want to pay for your visit, you can drop that in front of the client and they'll be like, whoa, that is a scary sounding diagnosis. Incomplete blink. Older dogs, tumors on the eyelid can rub on the ulcer and keep it from healing. Entropion, ectopic cilia, extra hairs, foreign bodies. These are all possibilities. So depending on the location of the ulcer, you should look for underlying conditions. So here, this is a lack of lubrication ulcer due to a dog that went under general anesthesia. And at our university, we ran out of petrolatum lubricant, so they switched to an aqueous one. And I'm like, that's awesome, except aqueous lubricant lasts 5 minutes. And funny thing, we had 15 post-anesthetic ulcers all in a row, and they seemed shocked. And I was like, you could have asked. I would have gone to Walmart and gotten you lubricant, I promise. So lube it up, and you'll do better. Okay, what is this guy? It's a really weird shape, right? It's very discrete edges. Turns out there was a stick sort of shoved up under the lid, and every time you blinked, it rubbed along this specific path. My favorite one was a Lhasa Apso, had a 2-week ulcer. I looked under his third eyelid, there was a complete cat claw, which he was like the luckiest unlucky dog ever. Anyway, I have to be the hero on that one. I was like, behold, cat claw. I also had a run of people who were feeding skinny pop to their dogs, and the popcorn pulls were getting suctioned onto their corneas, which was niche, but weird. Hey, why does this guy have an ulcer that won't heal? Well, because my resident, clearly not me, did this surgery on the eyelid and made the lube too long, and the ulcer is rubbing on the cornea. There you can see another look at it. Womp womp. It's exactly where it is. Okay, this is a horse, don't panic. You haven't been transported into the room next door. This is another eyelid laceration. They did a full thickness suture in that kept it from healing. And it was with us forever. So here is the tear film breakup time. As you can see, it's really obvious, right? No? So here's the idea. Tears are designed so that every time you blink, you get a sheet of tears that is evenly spread across your corneal surface, adhered with mucin, and with a layer of meiboom on top to keep it from evaporating. So if I put a little bit of fluorescein into the tear film, when I blink the eye, it should stay a clean sheet of green for 20 whole seconds. So you close the eyelid, you open it up with a blue light on it, and you start timing how long it takes before you get a dry spot with no fluorescein in it. And that means that the tears are evaporating before the natural blink cycle. So it should be 20 seconds or longer. If it's under 20 seconds, there you have it, qualitative dry eye. The treatment is the same as for quantitative dry eye, which you measure with a Schirmer tear test. it's optimmune or cyclosporin and tacrolimus. Having qualitative tear film abnormality is a little bit like having Rain-X on a windshield. The tears sort of bead up and roll off, as opposed to saying a nice clear sheet. So you can imagine how that feels. So what if it's a middle-aged dog, it's superficial, it's not infected, there's no underlying conditions that you can find. For safety, you've sent me a photo and I've said, yes, this does appear to be superficial and uninfected. That's when we come with the diagnosis of boxer ulcer, recurrent ulcer, spontaneous chronic corneal epithelial defect. That terrible name was coined at the University of Wisconsin where I trained. So I'm contractually obligated to call them SCEDs for the rest of my life, even though that is just a horrible, horrible name. This is an underlying problem with the body's ability to heal. So people who have recurrent ulcer syndrome will get ulcers from the trauma of their eyelids opening up first thing in the morning, or from the rapid eye movement during sleep. And then the epithelium grows over the wound, but it won't stick down. So every time they blink or scratch, it just sort of peels this unhealthy epithelium away. Okay. They can last weeks to months. My record is 5.5 years. Okay, this is not my fault. All right, it was a very old miniature poodle. We thought it was old when we started, which was at about 12 years of age. It had heart problems and every other problem. And she's like, you won't live long enough, so let's just keep treating it and we'll just let it ride. And every year I'd be like, he's still alive. Can we take him to surgery? And they're like, no. So he died with his ulcer. I like to believe his corneal nerves died as well, or maybe it was just his soul. I don't know. We've all seen that dog, right? It just comes in a baby carriage and all it does is bark, bark. You're like, yes, quality of life. I feel it for you. I say this, but that's what's going to happen to my Shih Tzu. I know it. I'm just going to stretch that bad boy out. So in these non-healing ulcers, weeks to months, they have a characteristic epithelial lip, which means the epithelium is growing over, but it's not sticking down. So when you apply the fluorescein, it dissects underneath the epithelium and creates the halo of fluorescein positivity. Okay. Now, this is not a disease of puppies. This is not a disease of the super young. When you see a non-healing ulcer in a really young dog, we saw a 8-month-old Great Dane recently, you have to look for something else. And in this case, he had an ectopic cilius, so that kept him from healing. There's usually very little corneal edema. 60% are vascularized, sometimes profoundly. Boxers in particular, they grow proud flesh like a horse. It's bananas. They can persist, however, for months or 5.5 years with no vascularization because the whole healing process is ducked up. So I consider this a disease of client communication. So I say there's something fundamentally wrong with your dog's ability to heal itself. We're going to give you eye drops to prevent secondary infection, but it's like having a broken leg. You can take antibiotics, but what do you need to get the broken leg to heal? You have to get the parts back together. You have to get the body to do the work. This is a mechanical problem that requires mechanical fixes. They often need to be treated more than once. They almost never get infected. They almost never result in loss of the eye. They're a huge pain in the butt. Once you have them in one eye, you're predisposed to get them again in either eye because the body's ability to heal is all screwy. Again, when in terms of topical treatments, I go with prophylactic antibiotics, just like a superficial normal ulcer, 2 to 3 times a day, something like triple or Oflox. Yes, ma'am.
this also what, I mean, when I was going through, they called it indolent ulcer?
Yes.
Okay.
Indolent ulcer, boxer ulcer, rodent ulcer, recurrent ulcer, you name it. It's all in the textbook somewhere. So when you look, I know this is histopath, don't touch, severe damage. Okay, the anterior stroma has this weird thickened layer. And the epithelium, which is that flappy bit up top, it just can't create these hemidesmotic attachments. So the treatment is focused on wiping away everything that's not stuck down and roughening up the surface of the eye so there are little places for the cells to stick. Okay, there's lots of different drops that have been advocated over the years, from serum to oxytetracycline, you name it, it's probably all been done. The most expensive artificial tear you can find, someone will tell you that that's magic. So far, no studies have actually demonstrated a clinically significant improvement in healing times. So I'm not against any of it, but I want the clients to spend their money on the procedures, because that's the thing we know will trigger healing. So what do we need to do? We need to wipe away everything loose. And I mean everything. If the whole corneal surface comes off, no biggie. The geographic size of these doesn't matter. I only get worried if it looks like they got infected and they start getting deep. And then we alter the stroma by scraping or drawing grid lines. And then we protect the epithelium during healing, because the healing is slow and abnormal. What about oculenus? It's a cross-linked hyaluronic acid. It used to be called Remend. You may have gotten the cell for it at some point. It's supposed to create a scaffold for migrating cells. So far, they haven't proven that it helps with this. I'm not opposed, but they also haven't given me money to do a prospective trial yet. So do with that information what you will. Okay, so epithelial debridement. Take a dry cotton tip applicator. Sterile is nice, clean is okay. Don't take it from a dog's ear to the eye, that would be bad. Numb the eye. I don't usually paralyze or sedate the patient. And you rub from the center out. And you may go through a lot of cotton tip applicators depending on how many tiers they're performing. Because the drier the cotton tip applicator, the better the grabbiness of it. People can also use the back of blades or excimer laser spatulas, because I know you've got one of those hanging around. With the Q-tips, they say you can't take off normal with a Q-tip. But I just got in a fight with one of the professors at the University of Florida who swore that you could. But I rub a lot of normal corneas with Q-tips and the epithelium doesn't come off. So I'm just going to knock him down one day and rub his eye with a Q-tip to prove my point. Don't tell him, he'll see me coming. This is Dr. Moore, we're actually good friends, Brett Moore, he's a good guy. So you want to wipe off everything that comes off. If you're using the back of a blade or something firm, you can take off normal. Okay, so be aware of that. I had a student who was in Alaska and one of their sled dogs had one of these and just called me in a panic. It was like 99% of the cornea has come off. I'm like, it's okay. They were like, you seem really calm about this. I said, I am. It's okay. So take it all. You usually have to go far past the edges of the existing ulcer. Once you have that tissue off, you can do a contact lens if you have them. Clients think they're super cool, or just topical antibiotics. About half of them will heal in 2 weeks, just with this procedure. You don't want them back in 2 days. Their healing process is slow and weird. They need time to marinate. Okay, so let's take this guy, relatively small when we got started, but it got real big. Why is there a peninsula of epithelial adherence, trademark Myrna? I don't know, but this section didn't peel off. A lot of times people miss the area under the third eyelid. I'm going to show you a video. It's going to seem pretty terrifying. This is a non-sedated dog with a indolent ulcer and just had a drop of proparacaine. This is a resident from many years ago. I insist on using this because he's wearing a suit. It makes him look really fancy. This is not how I do. So if there's no divots, if there's no depressions, if there are no weak spots on the eyeball, which is a huge if, eyeball is incredibly strong, right? When you rub your eye through your eyelid, you squish your whole cornea in, okay? So if you are confident that there are no divots or depressions, because if you do this to an infected ulcer, you're asking for trouble, you can be pretty darn aggressive, okay? You don't have to be this guy, that's okay. But I show it to you just so you have a sense. All right, here is a aluminum spatula. The thought here is you scrape off the corneal epithelium and you sort of roughen up the stroma at the same time. If anybody uses the back of the blade technique, that's the same idea. Right, you can do an anterior stromal puncture. This is humans. Physicians figured out that if there was a deep trauma, there was never a problem with the recurrent erosion healing. So the thought was, if I make little dit dots by tapping a needle across the eye, I can simulate deep trauma and it will heal. And when I say little, the tip of this needle is bent about 40 microns. If you want to make your own, grab a 25 gauge needle and bend 1/3 of the way down from the tip in the bevel. Like, it has to be very small. Or you can hold it with a pair of needle drivers with just the tip out. And then you can just tap it across the corneal surface, or you can drag your grid line. I like the bent needle approach because if the dog jumps into you, you won't stab them into the eyeball. Okay, this is what that looks like. This little bent tip is making little pop marks across the cornea. We use a lot of contact lenses for comfort. People have used third eyelid flaps. The idea is just a bandage. There's no proof that the contact lens or the third eyelid flap speeds healing. You do an antibiotic to prevent infection, and then 80 to 85% will heal with a combo procedure, where you wipe away the loose epithelium and you roughen up the corneal surface. Okay, you can do it when they're completely vascularized, but fair warning, tell the clients, your dog may cry blood. This is not something you want them to discover on their own. In the waiting room, they will say things. It's hard to come back from that. I'm just saying, I wouldn't know. I've not done that. Might have. Okay, here's a much more scarier photo. This is a little more pointy towards the eyeball than I like, but making little scratches there. Here's your classic grid where you go from normal epithelium across abnormal back to normal in 1 millimeter grid lines. This creates a little more scarring, but I've never had a dog complain about it. There is no success difference between scraping with the back of a blade, doing an anterior stromal puncture, a grid keratotomy, or a Diamondberg keratotomy. They all have the same rate of healing, which tells me none of them work awesome, or I would only teach you one thing. So if you like toys, this is a pretty cheap one to purchase. It's Algebrush 2 with a 3.5 millimeter medium grit tip. It's like $250. You can buy a couple of tips for it. The big thing about this is that you have got to clean this diamond dusted Dremel afterwards. So a brush and dish soap, and then put it through the autoclave. Otherwise, little bits of epithelium stick behind. And this is exactly what it sounds like. It's a little Dremel, and it burrs the surface of the eye and sort of polishes it. If that sounds utterly terrifying, we did a study where you have to hold it in the same spot at high power for 2.5 minutes before you achieve any meaningful depth. So you basically are just polishing. I know, I have been around it too long, I'm immune. So here is the same dog, unsedated, just topical. And here we're doing the diamond burr. Okay, the noise is low. Oh, my mic's not on, so that helps. It's really low, not a big deal. The thing is, though, that the conjunctiva is loose and covered in bacteria. So if you take this over the conjunctiva, it will whip into your Dremel tip. Okay, so you have to stay on the corneal surface. They recommend you do about a minute with this. It's got the same healing rate. If you want to try contact lenses, I really like the Bausch & Lomb Pure Vision 2s. These are Plano, no correction, because nobody needs corrected vision here. Bandage contact lenses, they retail for about $6 a lens, which is nice because dogs have a built-in contact lens removal system known as the third eyelid. So there's at least a 25% chance that they will pop that contact lens out on their way to the parking lot. So because of that, I use the cheap one. There are really expensive $50, $60 contact lenses that are fitted to dog corneas, but I wouldn't do that when there's such a high chance of them just popping out. This is what we use. What is the benefit here? You have taken a relatively small ulcer, you have at least doubled the size, and then you have literally scratched up the surface of their eye. So they're going to be way more painful walking out the door than they were walking in. This can make them feel a lot better. So that's the reason I like to use it. Putting in a contact lens is either incredibly easy or the worst thing you've ever done in your life. I was in a battle with a Boykin. You guys don't have as many Boykins out here. It's the state dog of South Carolina, so I see a lot of Boykins. They're small and they are intense because they are working dogs. And needless to say, he won. So I just put it on a Q-tip and I drop it in. If you use contact lenses yourself, you'll probably be better at putting them on than me, who's never, I can't even give myself eye drops. Sad. Contact lenses are 99.9% benign. So obviously I'm going to tell you about the 1%. Contact lenses are meant to float on your tear film. If they suction down to the cornea, that's called tight contact syndrome. It'll happen within 12 hours of placement and the eye will become acutely painful. Knock on wood, in 18 years of ophthalmology only practice, I've never had it. And I use a lot of contacts. You can leave them in for up to 2 weeks. Clients do think it is super cool. And they usually stay in better if you put a collar on. I know that's shocking. Here's what that looks like, the tight contact syndrome. So the eye will become acutely blue and painful. It has to be within a day. Most clients, if they call me up and say he was really comfortable and he's suddenly uncomfortable, my assumption is that the contact lens popped out. That's the most common. If the contact lens is still in at the recheck and you put fluorescein in the eye, it'll flood the whole contact lens and the whole eye will look green. So just a heads up. Also, in case anyone sends you a dog who's gotten a lens. Okay. When that fails, There is a technique with a report in the literature of 100% success. Not that I would tell a client that. And if we shave off the surface of the cornea under anesthesia with an operating microscope, it's called a superficial keratectomy. Keratos is prefix for cornea. Ectomy is cut a piece out. These have 100% success. You treat them like a superficial ulcer, they will heal. They leave a much bigger scar. So, yeah, this is one that had a superficial keratectomy. It's doing all right, but it's a lot easier than other techniques. So this is a hard sell. If someone's coming from a really long distance, I did my internship in Saskatchewan, and people would fly in from Alberta or something like that, because there was only one ophthalmologist in 2 provinces at the time. So if they flew 6 hours to see me, you're getting the surgery, because I need the sure thing. And then we're popping it back on the plane the next day. Okay, so which one's infected? Oh no, you have to participate again, I'm sorry. The right one. So this is a horse. It's geographically large, but there's no divots or depressions. Okay. So I've told you all these wonderful things about how the eyeball is super strong and would handle these procedures. Now I'm going to negate all of that by talking about ulcers that go badly. And these are your melting corneal ulcers, your infected corneal ulcers. So hopefully, right off the bat, you can see how much different these look. This one looks like a shark bite to the surface of the cornea. That's not great. This one, diffusely edematous, completely blue, blob of hypopyon. This one, the surface is melting off, leaving this dependent blob on the bottom. These will best be served a lot of times by surgical repairs, but you would be surprised how many you can get to heal with intensive management, even when they rupture. So we're going to talk about some of those. So what's happening? When we get a superficial ulcer, the vast majority are going to heal in 3 to 5 days, as I said. If it gets infected or the body's intense immune response is triggered, it sends white cells in, and both the bacteria and the white cells start to liquefy the unhealthy cornea. They're like, this cornea bad, slough it off. This would be awesome if the cornea was not a 0.5 millimeter thick. So this is why you can have an ulcer that is pretty superficial one day and overnight down to Descemet's membrane. Because once it starts melting and the enzymes are chewing away at that cornea, proteolytic, collagenolitic enzymes, they'll just chew through the whole thing until they get down to Descemet's membrane. And we have that desmetacele, and then that is very weak. So they have a good sneeze, the eye pops, the insides come outside. It's a whole thing. Okay, so here's what that looks like as it starts to get deep. You get the depression. When we have a desmetacele, you have a circular lesion with a black center because there's no longer any stroma to be edematous. So you're seeing right through that thin layer to the inside of the eye. And then you've got a pop. You have either fibrin or iris sticking out of the eye. So Pseudomonas is particularly nasty for this. There's also some strep species that just liquefy corneas. And so if I see rods on cytology, I think Pseudomonas, I get really worried. But even the body's own response cells will liquefy. Okay, so what does it tell us? When we see this abnormal corneal contour, when we see a divot, when we see a depression, it tells us that malacia is afoot, that infection is highly likely, that the eye is super fragile and requires intensive treatment, and then you have to watch it like a hawk. So unlike the indolent ulcer, where it may be geographically quite large, but it's superficial, you have to send them home for 2 weeks and let them do their thing. These you need to check every 1 to 2 days. Okay, so here is a slit beam where you can tell the thickness of the beam sort of disappears at the center. I found that for most laymen, using the slit beam is not especially helpful. But again, it sort of looks, this is how you would do it. You grab your direct ophthalmoscope, which is more than just a cobalt blue machine, I promise. And there's this beam, single line of light, and you look at the eye from a bunch of different angles. She's wearing jeweler's loops. I don't know anyone who does that. If you want to look cooler while doing it, you can get the highest grade reading glasses that you can buy at Walgreens, which I think are 4+, and some of them even have little reading lights on the side, and that's a good way to get some magnification while you're generally looking. Okay, so here's what the Optivisor looks like. Here are some Caddis readers, which are really expensive. If you go to Costco, you can get a 4-pack of 4+ reading glasses for like $25. They all will work, right? So then we're going to look for corneal infiltrate. As I said, corneal infiltrate are white cells that have gone into the corneal thickness to try and liquefy that infected area and get rid of it. So the more white and yellow things look, the worse it's going to be. It tells us that bad things are afoot. The worse the uveitis inside the eye, the worse the infection is. So we talked about spotting hypopyon or little blobs of pus in the anterior chamber. The presence of flare. Who can say with confidence that you see flare in general practice? Yeah, exactly. We teach it a lot. It's really hard to assess. So super small pupil, blue cornea, hypopyon, that can help you figure things out. Okay. So the malacia means that the body is healing. It means there's a lot of enzymatic activity. And this is a case where the drug that you apply to stop the melt is really critical to the chances of this healing. Unlike superficial uninfected ulcers, the drops are just to prevent a problem. Once an ulcer is infected, the drops are critical to the healing, and we achieve super high frequency. So the fluorescein staining pattern can help you too to tell whether things are superficial or deep. Things that look like divots but are green all the way through, that means you're not down to desmase yet. The classic appearance of the desmetocele is the green donut, where it's fluorescein positive all the way around, but then there's a black spot in the center. Corneal edema and vascularization are not super specific, but you can tell this is an uninfected ulcer. These are infected ulcers. They both have about the same blood vessel ingrowth, but the rest of the cornea is much clearer on the uninfected ulcer. So what do we do to confirm our suspicions? My favorite diagnostic is cytology, and I know that's sometimes scary to take a sample from an ulcer and an eyeball that is fragile. So you do have to be careful. They did a study at Florida that showed that the best samples come from the back of a blade, which is terrifying. So the worst samples come from a Q-tip, which is what most people reach for. So here is my compromise. Are these micro brushes? You can get 100 on Amazon for $6.50. They're called dental brushes or makeup micro brushes. The little plastic sticks with a puffball at the end. So it's a small investment, and it really, you just rub the fluff ball at the edge, dry, and it will exfoliate the cells. You should only see about 1 or 2 neutrophils in a normal corneal cytology. So if you see a bunch of neutrophils, best assumption that we are infected. We're definitely melting. You need to use stain that is free of ears and rears, because that stain is super gross. So clean stain, anything that you have for less gross parts of the body would be my recommendation. And it gives you an answer right away, which I like, because we read all our own cytologies in-house. Or you could take 3, read one yourself, send the other 2 off. And if I see cocci, then I'm thinking gram-positive, I'm thinking staph and streps. If I see rods, I'm thinking gram-negative. If I see fungus, I'm thinking, oh no, something really bad has happened, because that should only be in horses. And if I see little peanut yeast guys, then I think my stain is contaminated, that someone put in ear slide. Aerobic culture, this is great in concept. In private practice, I know it's really expensive. You only get a pickup maybe once a day. It's going to take a couple days for that to come back. The eye will probably be won or lost by the time you get your culture back. So academically, it's excellent, because you know what's growing in your area, you know what resistance patterns are coming up. But realistically, if I had to cut a diagnostic, that's the one I'd cut. Okay. So in terms of treatment for melting ulcers, we've got 4 big goals. The first, halt the infection. So depending on what you see, you can either do a late generation fluoroquinolone, your ofloxacin, moxifloxacin, every 2 to 4 hours. If you see a bunch of cocci on your cytology, those staph and strep species, those are really your skin bugs, right? So what would you reach for if you had a skin infection? You would reach for cephalexin. There's not a topical cephalosporin commercially available, but if you have the 1 gram intravenous vial, mix it up with a ml of sterile water, inject it in a bottle of artificial tears, and you will have somewhere between 33 and 55 milligrams per milliliter cefazolin eye drops. That's all we do. I'm not telling you to compound at home, but you could. Also, triple antibiotic, believe it or not, is a really great broad spectrum antibiotic. It's all about frequency. Once you get infection, is that you need to raise that from 2 or 3 times a day to every 2 hours. Just marinate the eye in antibiotic. You can overcome antibiotic resistance. You will achieve concentrations that are nowhere near what you would get with oral administration. Now we have to stop the melt, stop the collagenolisis. And the go-to for this forever has been autologous serum, which is blood from the patient with the ulcer that you spin down, you take the serum off, and you administer it. We have shown pretty convincingly that it does not need to be from the dog in question. And who wants to take 5 cc's of blood from a wiggly Shih Tzu with an eye that's about to pop? So you can take it from any dog you like. I would prefer a non-diabetic. We don't need to throw sugar on the infected wound. You can store it. So we collect the blood, we spin it down, we aliquot it out, and about 2.5 ml vials, we stick it in the freezer, just a regular -32. It's good for 6 months to a year. You don't necessarily have to throw it away after 3 days. You've probably been told all sorts of things. There's no real hard science, but there was a study in Iowa where they sent bottles of serum home with people and they put it in the fridge next to their cold cuts. And they gave drops every day and they didn't see any evidence of contamination until 3 weeks. I usually go about a week and then I have them throw it away. So if they're gonna need a lot of serum for a long time, you can give them multiple bottles or syringes frozen back. They can just take them out and thaw. But you'll see some ophthalmologists who only give a day's worth at a time in a syringe and then tell you to throw it away. And then the next day, I'm not that guy either. Now that I have it frozen in dropper bottles, which you can buy sterilely online, my life is so much easier. Yes, ma'am.
Did you use from a different species?
Oh, yeah. So it's like you knew what was coming. Okay. On, where's my cool thing with the horse? All right, never mind. We actually did a study at the University of Georgia that showed that horse serum has super, super high levels of that alpha macroglobulin, which is considered to be the key ingredient of serum that stops the melt. So if you have horse serum, you can put horse on dog, dog on cat, horse on llama, dog on pig. I have done all the things. And there's really no communicable diseases, which is super awesome. In vet med, we don't have a lot of things going for us with ophthalmology, but the fact that you can't give a serious disease from one animal to another is one of them. So yeah, who do you bank? Do you bank horses? Or
I'm going to.
yeah. Because then you can really go to town. You have to let them flock forever and ever and ever. You have to tell the clients it's going to be yellow, but then they should be fine. In fact, yellow feels more medicinal, so roll with it. So what stops collagenolisis? So we talked about the serum can be frozen for up to 12 months. Should only be used for up to 2 weeks before you chuck it. Refrigerate it when you're not using it, and yeah. You can send it home in bottles or whatever you like. One thing that has gotten some press is the use of oxytetracycline or other tetracycline antibiotics, which chelate zinc and calcium, which are necessary for the enzyme activity to melt the eye. So there was a trend for a while, or you still may be one of these people who uses oral doxycycline for its like magic stop melting properties. Or you can add topical terramycin in. The problem with this is that's another medication on top of medications that you're asking them to put in every 2 hours. So I'm not a huge fan of it personally. I want the least number of drugs to give me the maximum outcome. EDTA works. You can put 2 mils of artificial tears and an old school purple top, and voila, you have EDTA drops. N-acetylcysteine smells like rotten eggs, but it stops melt. Right now at the university, we basically use serum and Oflox. To start all our melting ulcers. We will add cefazolin if we see a lot of cocci, and we don't mess around with the other stuff for the most part. You want them to feel better. Scratches on the eye are not as painful for dogs as they are for people, thank goodness. They have 1/5 the corneal sensation that we do, roughly. So this is why dogs walk around with big clumps of hair on the center of the cornea. And you would be crying out to your deity of preference if that happened. So some systemic NSAID, sure. As I said, even with infected ulcers, I usually just give them a drop of atropine in-house. Or you can send it home with them. My young trainees are really into gabapentin, but I haven't noticed a huge difference. And then what truly is the drug of the young? Trazodone. Because I had never heard of this. And then 3 years ago, 4 years ago, all of my residents are like, I sent them home with 25 million Trazodone. And I was like, what? Okay. So I get it, like, it's wild. They'll be like, he was wiggly during his exam, so I sent him home with Trazodone for the next one. And I'm like, I am clearly a different generation, because I'm like, just hold them better. But if the eye's super fragile, and they're at risk of rupture, especially if they're a puppy, by all means. There have been dogs that I aced in the past, again, hashtag old, but yeah, GABA or Traz to calm them down. But I just feel like it's giving me tramadol vibes, like we were really into that for like 10 years, and then we're like, oh, it doesn't probably do anything. But yeah, trazodone. Okay, recheck them frequently, every 1 to 2 days. Because this can go south quickly. At least once a week until things are more stable. Okay, so what are we expecting? The ulcer may get a little deeper as all of that infiltrated stuff goes away. That's okay. They should be more comfortable, a little less yellow. Okay, so we're seeing them. We've got lots of blood vessels coming in. The clients may think it looks way worse. That's usually for 2 reasons. 1, they're holding their eye more open so they can see it. 2, the blood vessels are going in and they're like, my dog's eye is red and blue and I am white all over. So, and then when it's all said and done, we have a large diffuse scar, and we'll regain whatever amount of vision we regain. Okay, so stop debriding all the ulcers. This is why I do the scary part for the second half of the lecture. If it's melted, if there's depressions, before you take that Q-tip to the corneal surface, just send me the photo, please. Nobody wants to pop a desmetocel while debriding the eye, right? It's a sad moment for you. It's a sad moment for the client. If you've never had aqueous humor gush gloriously onto your face, as I have, let me just tell you, it's warm, right? Which we know as doctors, but it's still shocking when it hits you in the nose. So warm. Okay. So no grids. Okay, this is not a fundamental problem with the body's ability to heal. This is an infection. Scraping things across it will spread the bacteria. No, no, no. Yeah. Yeah. All right. So with desmetaseals, the treatment of choice is surgical. Because once you lose all the stroma in the center, you're down to desmase membrane, there's not really tissue to fill in the hole. If they can't do it, you have a couple of options. Nuclear option, take the eye out, right? Chances that it's going to heal are low. It could pop any day, that's stressful. Okay. If they're young, you got a decent shot at this. If they are old, you're going to end up one of those 15-year-old Yorkies walking around with an epithelialized desmetocel that's been there for like a year. And it's just a little time bomb in their eye. And one day it might pop, but it might not. So you do the same things. You marinate the eye in antibiotics and anti-melts. You keep them super quiet. You get them in an e-collar. You say a prayer to the gods of the corneal stroma, and you hope for the best, right? And then I don't like to take an eye out until it has ruptured. Ideally, I've done it. But I usually say, let's give it a shot and let's see, okay? So, okay, now it's ruptured, perforated. A lot of clients COVID was hard for a lot of reasons, but one is I couldn't look into the eyes of my clients when I said your dog's eye might perforate, and they're like, uh-huh. And I'm like, oh, you don't understand. Then you're like, it might rupture. And they're still smiling, and I'm like, your dog's eye is gonna explode. And I'm like, oh, okay. So what happens? The eye is a pressurized system like an airplane. So when the eye ruptures, it's like the window pops out of the airplane. There's an explosive decompression. All the fluid goes gushing out, and the loosest part of the inside of the eye, which is the iris, gets sucked into the hole like a stewardess, right? Okay, so this is the idea. If the iris doesn't plug the hole, the body will create a huge fibrin clot to plug the hole. So that's what that looks like. You've got a little bit of iris sticking out, you get a big blob. If you try to, is that valve for us? No, okay, good. I was like, yeah, let's do it. I see a lot of horses. Like 30% of my practice is horses. And eye disease in the South is really difficult. And these are mostly rodeo. I get a lot of barrel racers and cutters and things like that. I don't get the fancy horses. They go to Florida. So a lot of quarter horses in my life. And I swore, the one thing I knew when I went to vet school is I was never going to touch a horse again. So oops. I love them now, so it's all good. I don't love their eye disease, it's terrible. But, so what do you do when the eye is ruptured? There's a hole. There are two ways this is going to go. It will either stay plugged, it will remodel, it will heal over. You'll be left with some adhesions to the front of the eye, a big blind spot. Or it's going to leak, reseal, leak, reseal, leak. So if I am managing a ruptured eye and the clients don't want to take it out, I give them a hard number of days that we're going to try medical therapy. Like I will try it for 10 days. But if this dog comes back in and it looks terrible, I'm not going to leave him with a hole in his eye. We're going to take the eye out. So if it stays sealed, when they come back, the eye should look, the cornea is relatively clear. The pupil is whatever size you left it at. If it is leaking and resealing and leaking and resealing, the dog should be very painful. The cornea will be edematous, the pupil will be super small. The only thing I change in treatment is I add in a systemic antibiotic, because now there's a hole in the eye. So here's a ruptured eye. This is the rupture down here. They didn't want to take the eye out, medical management. This is what we're left with. Now, this is an 11-year-old French bulldog, so he already has enough problems, but how good is the vision on this eye? It's not great. You can see things coming down at him, which as a Frenchie is probably all you need. But that's what you're hoping for with medical management. So I am not, there's always options. They're just not always as great. By giving them a limit from on how long I'll try medical management, it seems to set expectations well, and it sets people up for success. Yeah.
Do you add any antifungal therapy to those melting?
No, I do not. And I get about one fungal corneal case in a dog every 2 years.
How about a horse?
Horse is totally different story. Every horse in my world is getting at least one antifungal, possibly two. I imagine in this part of the world, you're fine with just one because it's a little drier up here. In Wisconsin, I had a very high success rate with horses. And then I moved to Georgia. And there's fungus everywhere. And it beats me personally, I think.
Is silver sulfadiazine?
I love SSD. Yes, SSD, antibiotic and antifungal, cheap, right on the eye. Monostat vaginal cream has the 1% miconazole. You can use If it's not responding, we make up, voriconazole. We get the injectable, we mix it up into 15 mils and give it through the lodge system. Yeah, or itraconazole if you miss so. Problem is they're basically all azoles. And if it's not working, it's probably not gonna work if you just keep throwing another one out. The only dogs that get fungal keratitis, they're usually systemically immunosuppressed or they're living in a high risk environment. I had 2 dogs in a household get it because their house had flooded and then all kinds of things grew in the house and on their dog's eye. Okay, it's quiz time and then it'll be break time. All right, superficial or deep? Superficial, all right. Superficial or deep? Yeah, there's something wrong here. This dog ran under the couch and yelped and came out looking like this. So does anyone know who the culprit is? Cat, yes, nature's cataract surgeons. So this is cat on dog violence, super common. Cat claw went in. This one was seen by our ER department. They weren't entirely sure what they were looking at, so they thought this was a foreign body. They grabbed it with forceps, it started bleeding. They ran for the hills. Owned by a very strange couple that sold pewter at the Renaissance Fair. So they left this puppy behind. We actually surgically corrected it. We put the iris back in and closed the wound. This is a really good candidate for conservative management, but I would do the same approach. Like we'll try 1 week, 10 days of treatment. And if it stays sealed, they'll probably be okay. Anyone who does rescue work and is pulled like 52 Shih Tzus out of a hoarding situation, if you look at the eyes, at least 10% of them will have healed corneal ruptures that must have healed on their own. So it is the body's attempt to fix things. All right, superficial or deep? Deep, yes. Superficial or deep? This is superficial, but there's all this crazy swelling around. Turns out this dog was exophthalmic from a retrobulbar abscess, couldn't blink properly and got this ulcer. So it came in for the ulcer. And I was like, guys, did you not notice his eyeballs hanging out of his noggin? I take these moments. Maybe I'm smug, I don't know. But I never get to save lives, so I have to take my moments where I can. This is the trade-off I made by becoming an ophthalmologist. I never get to be a real hero. I'm not making it on the shuttle to Mars, is what I'm saying. I am superfluous to society. All right, this, well, superficial or deep? Deep, right? So big, but desmetocele. This is quote unquote healed. All right. The epithelium has grown down the sides. When you stain this, nothing picks up stain. And this is the problem of medical management of the desmetocele. Once the exposed stroma is covered with epithelium, the body thinks it's healed and all the blood vessels back away. And so you're left with this enormous weak spot that instead of just desmoid membrane is desmoid and epithelium. So this is not a reasonable state to be in. This is definitely going to rupture. Superficial or deep? Well, it's kind of a weird one, right? It is superficial. It's got a little bit of rim of epithelium around it. What is disconcerting is this dog got into the leftovers and it ate so much fat that the fat went into the bloodstream and it spilled into the aqueous humor. So that is lipid-laden aqueous, which is probably a once in a career thing if you happen to see it. And obviously you're more worried about the dog having like pancreatitis, but it does happen. I had a little diabetic miniature pinscher who on the way to see me was given the treat of a hot dog from the varsity And by the time they got on my table, their eyes were full of fat. So we had to have a conversation about hot dogs and diabetes, which they probably wouldn't have listened to until they saw their dog's eyes. Okay, superficial or deep? Deep, we've got hypopion, we've got mad blood vessels, we've got a little divot there. This is a Pekingese. His nasal fold is rubbing directly on his infected cornea. So that's cool. Okay, so this is beyond deep. You guys see the dent up there? This eye is collapsed. So when they try to open the eye, they squish the eyeball. What's intriguing about an eye like this is that I could still fix it as long as the back half of the eye sees okay. So if you were to call me and say, I need to send this in, they want to do everything possible to save the eye, I would ask you one critical question. Is there a consensual from this ruptured eye to the good eye? Because that tells me the retina and the optic nerve are working and it's worth the drive to come and see me. I'd probably do a frozen corneal transplant plus minus a conch flap, and he could regain vision all the way up around these parts. You could also just take it out. I mean, what dog needs two eyes? Did I just say that? Don't listen to me. I have a cat with no eyes right now, and I swear she sees better than everybody else. She chases bugs on the other side of sliding glass doors. Yeah, it gives you perspective. Okay, we already looked at that guy. Here's another heel desmetaseal. So all the blood vessels are gone. It is not going to fill in the defect. Superficial or deep? Superficial. That's just a big nasty mess. Big dry spot. He's got a tarsorrhaphy in place. This was a proptosis that was inadequately closed. This is an interesting one. It didn't look that deep. So we went to do a cytology and the whole corneal surface just mushed around. This turned out to be a chemical wound. So something splashed into the eye. Bases are worse than acids, but neither of them are great. So we did a pH strip on him, and it was really basic, and we had to flush it. So do you know when you get something in your eye, how long you're supposed to stand at the eye wash station? It's like 5 to 15 minutes, and about 30 seconds feels adequate. So when I say we flushed this eye, I don't mean we ran. We squished one tube of eye wash on him. We sedated him and hung him in the sink and turned on the faucet and did it for 15 minutes. So here's our little baby Deep. And yeah, let's take ourselves a break unless anyone's got questions. In Latin, Greek, Latin probably means break, so that's not super helpful. But the way I think, if you look at the eyeball, there's a fibrous part, that's your cornea and your sclera, and then there's the neuro part, which is your retina, and the bits in between are the bloody bits. And that's what the uvea is, and by definition, it is the location of the blood-eye barrier. Anteriorly, the blood aqueous barrier, posteriorly, the blood retinal barrier. So by definition, uveitis means there has been a breakdown in that barrier, and things in the bloodstream that aren't supposed to get into the eye, get into the eye. And that is uveitis. And if you think about it that way, it makes sense that the majority of uveitis is caused by disease elsewhere in the body that's manifesting in the eye. But let's start with a case where the problem is very much the eyeball. Okay, so are we in porcupine country? All right. So when I show these to my students in Georgia, they're like, what is happening? I've never seen this. And I'm like, in Saskatchewan, I had like 2 a week. So I was covering emergency for one night during my specialty internship, and this walked in the door. So what can we see immediately if we look beyond the rage that is Skipperkey and the mouthful of quills? In the left eye, the pupil is much, much smaller than the right. So one of the quintessential signs of inflammation inside the eye. And there is a quill sticking out of it, so that seems bad. All right, you gonna play for me? There you go. So as he looks around, that quill is in there, man. It is jammed. So why does this dog have uveitis? Well, it's trauma. So in a perfect world, I would take this dog to surgery. We would surgically excise the quill. They didn't have the money for that. So what would you guys do? Yeah, get out, baby. Okay, that's what I did. So after we pulled all the other ones out, I saved it for last for maximum dramatic effect. I pulled the quill out. There was a squirt of aqueous humor. Body plugged the hole. They didn't even have money for eye drops, of course. So I pulled a bunch of stuff out of the donation drawer and I sent him home. And because he never came back, he obviously did great. Right? This dog was so mean, we had to propofol him to put his e-collar back on. So honestly, I don't know what we would have done. So sometimes it's really obvious. Trauma directly to the eye will cause uveitis. If you can control the source of the trauma, in this case, the perforation, and treat with some systemic antibiotics, systemic anti-inflammatories, things should resolve. It's pretty straightforward. Okay, so the uvea, that's your iris, your ciliary body, which sits around the lens and makes your aqueous humor. And then the choroid, which is the vascular layer between the retina and the sclera in the back of the eye. And uveitis is a breakdown of that. So lots of different names for this, depending on how fancy you want to be. Anterior uveitis means that the problem is in the anterior chamber and the aqueous humor. Posterior uveitis, the problem is between the retina and the sclera. That's where you have retinal detachments, things like that. Any of the structures involved, you can throw an itis on the end and you can be living your best life. Cyclitis is a ciliary body, which is that sphincter that makes the pupil small too. So the hardest thing about uveitis is reliably identifying it. Because we talked about how hard it is to see flare and believe that there's flare. So my approach is going to be 3 clinical signs. And if you have 3 clinical signs, you can reliably say that it's uveitis. And I will show you some pitfalls to avoid where just 1 clinical sign sends you the wrong way. Once you know that there is uveitis, you need to decide what's causing it, right? So there's a very small number of diseases that are localized to the eye. Everything else is presumed to be related to systemic disease, but frustratingly in all the literature, 60% of uveitis cases have no identified cause. So idiopathic. And lastly, we're going to treat it. And so the normal eye should have a relatively white sclera, nice, clear, avascular cornea. Pupils should be mid-range in ambient light, constrict and dilate appropriately. Sometimes you get a dog that's pretty jazzed to be in your practice. And so the episcleral vessels will plump up. And so they'll have kind of a red eye every time they come to see you. Also, if they've had inflammation in the past, they grow new blood vessels. And so small irritations will make their eye look really, really red. It's fun. Non-specific signs, corneal edema, ciliary flush If you can spot this 360-degree blood vessel ingrowth at the limbus, that is a strong indication that there's disease inside the eye, whereas superficial disease is more likely to be these tree branches. Real life is more complicated than that. Scleral injection, the episcleral vessels leave the limbus perpendicular, and they're those deep straight vessels as opposed to conjunctival hyperemia, which is superficial vessels. Conjunctival hyperemia is supposedly superficial disease. Episcleral injection is intraocular disease. Again, real life, you usually have a mix of both. Here's just a really nice episcleral injection. If you're a scientist, if you put a drop of phenylephrine on there, episcleral vessels would not blanch, but conjunctival would. If you're a cheaper scientist, as I am, if you touch the conjunctival with a Q-tip, only conjunctival vessels will move, whereas episcleral vessels will not move with a Q-tip. Changes in the pupil size can be very subtle, like this dog where the left eye is slightly more dilated than the right. This is best appreciated with the lights down and a light source from like arm's length away. If you can get those tapetal glows, you can really see if your pupils are different sizes. The pathognomonic finding for uveitis is aqueous flare, which is just a manifestation of this physics property called the Tyndall effect, where particles in a, all right. Basically, light is bouncing off the particles, and you can see the light as it streams through. So if you hold the laser pointer to the side of a glass of water, you shouldn't be able to track that laser beam as it goes through the water. But if there is increased protein or cell, you can track the light as it passes through the fluid. This is the same reason we see dust in sunbeams, we see rays of light. If we wanted to play laser tag in this room, which, let's be honest, would make the morning go really fast, what would we do to make sure you could see the lasers go across the room? We would fill it with a smoke machine. Uveitis is like a smoke machine inside the eye. It allows you to track the light as it passes through the anterior chamber. Do laser tag things even exist anymore? I don't have a modern equivalent for this. So how do we see flare? You get the darkest room you possibly can. You get the brightest, sharpest light that you have. My favorite is the small dot on your direct ophthalmoscope. You hold it really, really close to the eyeball. You should see that circle of light or that beam of light on the cornea and the second dot on the lens. And then you look from the side to see if you can connect the dots, right? In real life, multiple patients, a treatment room, not being able to make it pitch black, light from commercial ophthalmoscopes diverts, so it makes everything a little muddy. I get that flare is really hard to see unless it is crazy severe. Okay, so let's do instead a combination of clinical signs. So that could be corneal edema. It could be chorotic precipitates. So if there's white cells in your anterior chamber, the aqueous humor flows like this in your anterior chamber, and the white cells will stick to the backside of your cornea. So it looks like someone stood inside the eye and had a really violent sneeze against the back of your cornea, and that's chorotic precipitates. Chorotic of the cornea precipitates out of solution. Cats are notorious for this. They make big, beautiful chorotic precipitates. Here's one in a dog. It looks like He drank coffee before he sneezed, so you have light brown dots on the inner surface of the cornea. Blood, that one we feel really comfortable with. If there is active bleeding into the eye, the blood-eye barrier is definitely not intact, so by default, you have uveitis. Hypopion or pus in the anterior chamber. Iris changes. The pupil will be small. The iris could look reddened. This is really notable in golden-eyed patients like cats. For blue-eyed patients, you can see actual petechia, rubeosus iridis, if you like eyeball terms that sound like Harry Potter spells. My favorite is Arcus lepoides, because that definitely feels magical. Fibrin, big blob of fibrin in the anterior chamber or consolidated blobs of fibrin. All potential clinical signs. The longer you've had uveitis, the more adhesions you get. So the iris can stick to the lens. That's posterior synechia. The iris can stick to the cornea. The cataract will form. Lens and cornea get their nutrition by the fluids that bathe them, right? So if your tears are unhealthy, your cornea is unhealthy. If your aqueous humor is unhealthy, the backside of your cornea is unhealthy and your lens is unhealthy. So it makes sense you would end up with cataract. Once you have enough adhesions, the drain stops working and the pressure goes up. You can have retinal detachment. Ultimately, all this could lead to a blind and painful eye that needs to be removed. So it's a nasty situation and time is of the essence. Here's some posterior synechia. It looks like someone just took an artist knife and just smeared the pupil edge onto the cornea or onto the lens. If you tried to dilate this, that part would stay stuck. Cataract. This is a little bit of a challenging one because we know that rapidly progressive cataracts can cause uveitis. Chronic uveitis can cause cataract. So my rule is if the lens is completely opaque and the eye is on fire, there's a good chance the cataract caused uveitis. Whereas if it's only a partial cataract, it's less likely that the lens caused the uveitis. Okay. This is when everything has just gone terribly. We have a complete cataract. The pupil is stuck down. A fibrovascular membrane has grown across the iris. This eye is unable to dilate, and it is on the road to secondary glaucoma. A retinal detachment occurs because fluid or inflammatory cells ooze out of the choroidal blood vessels into the subretinal space and push the retina up and away. Glaucoma is usually because of scarring inside the eye. So one of the double whammies that's really sad about glaucoma caused from inflammation is that it's highly resistant to treatment because ultimately you can't unstick the iris once it scars down. So before we go on the hunt, we're going to make sure there's no primary cause of glaucoma, or excuse me, God, maybe I did need a coffee during the break. Let's get it together, Myrna. All right, make sure there's no primary cause of the uveitis. So I think there's uveitis. The pressure is low, the pupil is small, the eye is red. The pupil is small, there's hypopion, and there's some corneal edema, 3 signs. Not just one low pressure reading, not just a red eye, but at least a couple of things that make me think it's uveitis. What is isolated to the eye? Well, we just talked about how ulcers can cause severe uveitis, so that's the first thing you're going to check for. But luckily, I know for every red eye, you do tears, stain, and pressure, so you would never miss that. Intraocular tumors, Those usually arise from the iris or the ciliary body, so you're sort of counting on being able to see them directly. Lens-induced uveitis from rapid onset cataracts, those are usually diabetics or juveniles. And then trauma, like the quill that we saw, or the Boston Terrier who tried to catch the golf ball at the driving range. He didn't. And then it becomes client education and trust. So it can be a hard sell. You brought your dog in because his eye is red and he's squinting. And my concern is, okay, we're going to treat the eye, but I'm worried that there's something going on that could threaten your dog's life. What we're hoping is we're going to run a bunch of diagnostics and they're all going to come back normal. So I want to spend a lot of your money so that we don't find what's wrong, and that's the ideal outcome. So $1,200, please. Don't use that technique, for the record. You can do better than that. So you figure out if it's just the eye or if you think it's elsewhere in the body. You're going to start treating the eyeball no matter what while you figure out what's going on. Okay, so you do a good physical exam, including your ocular exam. And if you don't think it's a primary ocular problem, then we have to go to a physical. I've heard tell you can listen to hearts. I haven't done it in like 5 years, but this is what they tell me. Some basic blood work. If it's an infectious disease, usually the CBC will be out of whack. If it's bad enough to cause inflammation in the eye. And then the advanced testing is really dependent on where you are, what's common in your area, what your physical exam recommends. Because just about anything that's ever been described has an article saying it can cause uveitis. So Antec now, or is it IDEX, has a uveitis panel. It is really nice. It's expensive. It's like $800, but it tests for blasto, neospora, toxo, cryptococcosis, all the tick diseases. So that's kind of nice. And just know that you can do every single diagnostic test plus 10, and 60% of the time, it's still going to be idiopathic. You never figure out what's wrong. So I usually go in stages. Physical plus minus basic blood work, and we start treating the eye. And we look to see if it gets better. If it's not getting better, I can sell infectious disease testing or imaging. If it's still not getting better, then we're looking at diagnostic eye removal or referral for advanced diagnostics, depending on what you've got, ultrasound and lymph node aspirates, etc. Okay, so look at all these causes. It's just the worst. So you have to use your index of suspicion to guide what tests are appropriate. Otherwise, you're going to have a $5,000 diagnostic bill, which is what you get if you have uveitis and you go to the ER. You've got an MRI, a CSF tap, every possible infectious disease test that's ever been invented by man. But we don't live in that world. Cats, similar to dogs, but the viral diseases pop up higher on your list. So young cats really think FIP, older cats, feline leukemia and lymphoma, and then toxo, still a common cause of uveitis in the cat. Regardless of what you think the cause is, and there could literally be a blasto organism in the anterior chamber waving at you, you are going to start actual steroids at a frequency that reflects the severity of the disease. So when I say actual steroids, there's really only 2 real topical steroids on the market right now. That's dexamethasone, which is usually sold with neomycin and polymyxin in it. And there's prednisolone acetate 1%. Hydrocortisone is not strong enough. So triple HC is right out. If you have Genocin Durafilm, which I think they're bringing back to market, which is betamethasone, the steroid should work, but the way that it was formulated is it doesn't penetrate the eye, so it doesn't work. So obviously, the only reason not to use steroids on these eyes is when there are corneal ulcers present. Otherwise, you start. And like antibiotics, in ophthalmology, steroids and antibiotics are drugs that you dose with your heart based on how bad it looks. So it could be twice a day if it's super mild disease. It could be up to every 2 hours if the eye just looks absolutely terrible. You have the benefit topically of being able to combine steroids with non-steroidal drugs without the risks of GI problems. You can't do that systemically, but it has a slightly different mechanism of action, so you can use predacetate and diclofenac. Whatever is cheap and you can get from the human pharmacy works for me. Fluoroprofen is pretty much impossible to find now. We're on a diclofenac kick, but that was off the market, so we went to ketorolac, bromfenac. I say whatever, the Fanac, it doesn't really matter. They all work about the same. The only thing that will give me pause is if you have a patient who's very small with bad kidneys. And in that case, if you're doing 4 times a day eye drops, you may achieve systemic levels that could be detrimental. I've only had that happen a couple of times in my career, and they were super geriatric cats with chronic kidney disease and the topical non-steroidals. That and eagles, but I don't think any of you are treating eagles. But they're very sensitive to NSAID sometimes. All right, in the meantime, we want to reduce the amount of scarring that occurs inside the eye. We want them to feel better. And we're trying to prevent the development of glaucoma. So if the pressure is low to start, go ahead and give them the atropine. It will make them feel better and it will reduce the contact between the iris and the lens. If, however, the pressure is already normal to high, you have to scrap the atropine because that can make glaucoma worse. And you can start them on glaucoma drugs that work for secondary glaucoma. So my go-to for secondary glaucoma is dorzolamide. It's a carbonic anhydrase inhibitor. It works in all species, horse, dog, cat. It works for all flavors of glaucoma, primary, secondary, malignant, aqueous humor misdirect. And it's very safe. And that should be, if the pressure is already high, you do it 3 times a day. If you're worried it's going to go high, a prophy dose would be twice a day. We use a lot of the combination drop of dorzolamide and timolol. That's, the brand name is Cosopt, but it's generic now. The one glaucoma drug you want to avoid in uveitis, if at all possible, is latanoprost, which is a prostaglandin analog. And we don't want to activate more prostaglandin receptors. We don't want to, and this has the side effect of making the pupil really small. So that's a no. Systemic steroids would be the best if you knew what the cause was. So an anti-inflammatory dose, this can be nice when your patients have corneal ulcers, but it can worsen systemic disease if they have it. So use with caution. Systemic NSAIDs are what we reach for when we're not allowed to use steroids yet. And we mostly stick with carprofen We'll do the Onsior in cats sometimes. And then for chronic immunosuppression, for uveitis that won't resolve, that's when we reach for the mycophenolate or the leflunomide or the cyclosporin. And these are very specific subsets of uveitis where they move into an autoimmune process where the disease won't ever resolve. So these, if you ever get to this point where you think your patient needs to be chronically suppressed, go ahead and talk to someone about it. Make sure you're on the right track. So for us, this is usually uveo dermatologic syndrome, which used to be called VKH, where the body attacks melanin-containing cells in both the skin and the eye. And these patients depigment, so their fur will go white, their noses will go pink, their eyes will go on fire, and they need to be immunosuppressed for their whole lives. Okay, let's do cases, because cases are better than blank slides. Okay, so this is Luna. Luna is a 9-year-old female spayed Australian Shepherd sent in for blindness. So when we look at this eye, the eye is red. There's both conjunctival hyperemia and episcleral injection. There's corneal vessels, although they look superficial. The tapetal reflection is dull because there's diffuse corneal edema. And then in the anterior chamber is a lovely parfait of pus and mud. So just seeing these, I can say immediately this patient has uveitis. I'm going to stain the eye to make sure there's not an ulcer. I'm going to check the pressure to see where we're at, and we'll go from there. So it turns out she's had red eyes for the past 4 to 6 months. Right eye started first, left eye came later. Was treated with triple antibiotic in both eyes, but did not respond. So I ask you, what is the only clinical indication for a topical antibiotic in dogs and cats? It's ulcers. That's the only strong indication. Dogs do not get bacterial pink eye that needs antibiotics. They need anti-inflammatories. The only exception for this is maybe your cat with chlamydia or mycoplasma, where we give a cat antibiotics for conjunctivitis. But usually what that says to me is I wasn't sure what I was treating, and ophthalmologists made me terrified of steroids, which, you know, we do. So we bump into objects now. They have a house in Wisconsin, which when you're from Georgia, that's meaningful because that means you're in blasto country. It's not on any flea, heartworm, or tick preventative because thankfully there are no mosquitoes in the state of Georgia, or fleas, especially not mutant fleas that took me 2.5 years to get rid of that were resistant to 3 different flea-killing drugs. It's like they're growing stronger every year. Frontline, haha, no. You need multimodal therapy. For the days of Wisconsin, sometimes I really wish I could go back. Has been doing well otherwise, so not a sick dog, eating, drinking, full of energy. Had some blood work at some point, but seemed okay. When we look at the eyes, the right eye has a normal Schirmer. Pressure in the eye is 42, so that's high. We have glaucoma, no ulcers, is injected, edematous, vascularized, has no pupillary light response, has the hypema, the hypobion, the flare, posterior adhesions of the pupil, rubiosis iridis, iris bombay, cataract, and the eyeball's enlarged. So does anyone know what the prognosis for the right eye is? Okay, in general, he's already blind from the cataract, but he's also blind because the pressure is so high that the eyeball has enlarged. In general, ophthalmic means blind. So it's game over for that right eye. So our only goals in the right eye are gonna be comfort. The left eye, also menace negative, has a normal intraocular pressure, deceptively high pressure for having flare and chorotic precipitates. I would hope that it would be abnormally low, like something between 5 and 10. Incomplete cataract, but when we looked in the back of the eye, his retina is detached. So will this eye see again? No. Once the retina is detached, probably game over. So we've got 2 eyes that are completely dead, no chance of vision for an unknown cause that is almost certainly systemic because it started in one eye and it went to the other. A cheap way forward to make the dog more comfortable, try to get yourself some answers, would be to just take both the eyes out and send them to a pathologist. You would do a little bit of pre-op blood work, look for anything glaringly wrong, and then you would hope that the pathologist could tell us what's going on. That is a hard sell. It's the first time you've met the clients. So here's what we did. We found the physical to be unremarkable. We discussed the uveitis workup and the fact that, and wanted to hear about the travel history. We talked about taking the eyes out, that we may get more answers from PAP. And they decided to do part of the workup. And they would think about removing the eyes. So at the basic, we did a minimum database, CBC, MUA, which was normal. We did a 4DX snap, which was negative, which is shocking because honestly, isn't one of those always a little positive? I think they designed that thing just to muddy the waters. We did a blastourine antigen, which was negative. We threw an ultrasound probe on the eye to make sure there was no hope of regaining vision. Turns out both retinas were detached. In the meantime, we want to get his eyes as comfortable as possible. So the eye with the really severe inflammation, we put on 6 times a day Neopolydex. The eye with the milder inflammation, we put on 3 times a day. We started glaucoma drugs to bring the pressure down in the eye with a pressure of 42. We started them on systemic carprofen because we had a high index of suspicion for an infectious disease. And we checked him back in 7 days while we waited for test results and to figure out where we were going to go. So in a week, no improvement. Okay. The owner chose to remove both eyes as it turns out that a blind Aussie who feels awesome is really hard to treat 6 times a day. So we took out both eyes and we sent them to the Comparative Ocular Pathology Lab of Wisconsin, which is the premier global lab for eye pathology. And we're like, surely we're going to get an answer. No. So I checked in with them. It's been 5 years since we took the eyes out. That dog is running like a beast. No idea what happened. Right? So where could things have gone differently for Luna? We could have seen them when the eye was first red, or right after the second eye started being red. And proper steroid treatment might have preserved the eye, so we had a chance to figure out what was going on. It's possible that this is where we were going to end up no matter what. So starting off with a really inspiring case for you, where nothing worked and the patient went blind. Okay. Oh no. And now we're going to move to a 5-month-old female domestic short hair. Okay. So this little kitten was sent in for a cloudy eye in the left eye. It was adopted a month ago. It's a really chill kitty. Really chill. Last week, the left eye went blue and it's been on systemic antibiotics with no improvement. All right. So if uveitis is the breakdown of the blood-eye barrier. If this were bacterial, where would the bacteria be? In the bloodstream. Your patient would be septic. So if you're choosing empirical treatment for uveitis, Clavamox is not a good choice because the patients with bacterial uveitis are usually septic. So that's your septic fold, that's your poor doer, or your really debilitated patient. The only time you can pick an empirical antibiotic for the treatment of uveitis is doxycycline, and that's because it treats those organisms that live in the limbal space between real bacteria and spirochete gland. So it's like everything with a fever of unknown origin is going to get pred and doxy before it dies, right? But plain Clavamox, cephalexin, these aren't good choices. So the right eye looks normal, the left eye is blind, the pressure is 32, so it's elevated. What tells us there's uveitis? He's got a small pupil, he's got corneal edema, he's got a blob of fiber. So there are your three signs. He seems bright and alert, although he appears to have lost weight, but that's comparing our baby scale to the referring vet's baby scale. But when we did a physical exam, his belly did seem sloshy. So does anyone know why our kitten has uveitis? FIP, right? Almost certainly. Now, usually uveitis secondary to FIP in cats is the dry form, not the wet form, usually, although it can be an equal opportunity. C2C, neutrophilia, increased proteins, hyperglobulinemia. Like you couldn't ask for this case to be more textbook. When we did an abdominocentesis, we had modified transudate globulins. Okay. This was in the olden days. So we talked about how FIP is terminal. In the meantime, we started treating the eye with prednisolone acetate, and we treated with dorzolamide to bring the pressure down. Eventually, the right eye developed uveitis. He became lethargic, stopped eating, and was euthanized. So now what I would do is I'd be like, this is FIP. There's nothing we can do. And I would leave a sheet of paper on the table with a Facebook group on it. I would never tell anyone to buy black market drugs in a grocery store parking lot, not as a doctor of veterinary medicine. But I've had like 5 cats cured now from FIP with the new drugs. And there's clinical trials going on at Cornell and Davis and in Canada. So it's going to be off the black market soon. Does everyone know what I'm talking about? These weird FIP groups that slip you the goods. It's kind of amazing because I don't have to give a lot of animals death sentences, but kittens with uveitis were always high on my list. And now if they've got the money, they've got the cure. And when it becomes legal, then it'll be a lot easier. So we ended up euthanizing and because the FIP wasn't getting better, wasn't being treated, the eyes really didn't respond to treatment. And that's often the case. Like if you have a patient with lymphoma, treating the eyes won't make the eyes much better, not until you put the lymphoma into remission. So response to treatment can be a good indicator of whether the disease is serious and ongoing. Here's Methuselah. So Methuselah, and this always makes me wonder, do you name your kitten Methuselah because you think he's gonna live like a really long time? Or can you only name a cat Methuselah if you adopt him at like age 12? I never got to ask that question but it haunts me. Right? And I figure maybe the next animal I get, I should name like a notoriously long-lived person name. And maybe that will inspire them to live forever. So this is Methuselah, 13-year-old domestic short hair, presents for a cloudy eye. History of an ulcer that was quote unquote partially responsive to terramycin. Not sure what that means. Indoor outdoor cat. So when we look at this eye, we see the sneeze effect of peratic precipitates. We see that the iris is abnormally red from rubeosis iridis. So that's only 2 clinical signs, but they're good enough for a diagnosis of uveitis. When we look at the left eye, that looks pretty normal. Note that because it's a cat, it has an abnormally low Schirmer tear test, because Schirmer tear tests in cats are very unreliable. We don't know why. Someone did this great study. They took a bunch of cats, and half of them they gave Schirmer tear tests to after they had acclimated. The other half, they walked around outside the door smashing cymbals to stress them out to see if it dropped their Schirmer tear test. It didn't. So we don't know why. It's completely unreliable. But I just wish I was on that study so I could march around like a little kid with cymbals, freaking cats out. And they were student owned, so they knew what they were getting into. And I'm like, you probably heard worse at home with a typical vet student. So this eye has a pressure of 33. It's super common to get this secondary glaucoma. The pupil is small. The menace is negative. He's red. He's got the peratic precipitates. He's got the rubeosis iridis and has flare. So that is Barrett's. So our diagnosis is uveitis with secondary glaucoma, which is starting to feel very familiar at this point. So the conversation with a cat is still, it's overwhelmingly secondary. We're still going to rule out the primary intraocular causes. In cats, they don't get inherited or diabetic cataracts, so they shouldn't have a cataract that causes lens-induced uveitis. They are less susceptible to blunt injury because they're cats and they're smarter. I won't say the same for Persians. They're not always so bright and their eyeballs are sticking out of their head. Ulcers, the big one for cats is that they can get the iris melanomas that cause uveitis. So that's the primary ocular disease that I'm most likely to rule out in a cat. My phase 1 diagnostics, good physical and a history. My phase 2 are chest rads, CBC Chem UA, FELV FIV SNAP test, and then fungal or toxo titers. This is an indoor outdoor cat. And then your phase 3, which is usually when the ship is sinking anyway. That's when I take samples from inside the eye, or I'm taking the eye out, or moving to advanced imaging. So what did they decide to go for? They did the SNAP test. They allowed the CBC and the chemistry, urinalysis, and it's a 13-year-old cat. I'm contractually obligated to run a T4. That's not because I thought the thyroid caused uveitis. While we were waiting on results, we went ahead and started that predacetate dorzolamide. The pressure came back down, which is great. The flare improved. The KPs, which this is a zoom of the peratic precipitates blobs on the backside of the cornea. The cat was more comfortable. He was feeling better. I'm thinking to myself, awesome. I am mighty and powerful. The cryptococcosis titer was negative. The toxo had high IgM and IgG. So IgG is more indicative of exposure. IgM should indicate active infection. So we're gonna put that on the list of possibilities. Chest rads, normal. Abdominal ultrasound was declined. So like we have already spent a lot of money and my cat's getting better. We continued topical therapy and we started oral clindamycin for the presumed toxoplasmosis infection. Because this is a cat on topical steroids, of course, it became acutely painful because it ulcerated. 80 to 90% of cats have been exposed to the feline herpes virus. It usually goes latent in the body. And when you topically immunosuppress a cat eye, there is a good chance you will awaken the herp, which will rise up and ulcerate the eye. So we presume that's what happened. We also know this cat has a history of ulcers that were hard to heal. So we had to stop the topical steroids. We added an antibiotic, and we counted on systemic anti-inflammatories to try to control the inflammation. Ultimately, the pressure came down and it stayed down. We were able to wean this cat off of dorzolamide. Cat got its vision back once the inflammation reduced and the pupil opened up. The ulcer would not heal because it's herpetic. So we added an antiviral. And so instead of healing, it then developed a corneal sequestrum. The tox are tighter. We did 3 weeks. We repeated after 3 weeks of clindamycin, and the IgM and the IgG were exactly the same, but the patient was better. So was it the toxo? I don't know. I did get to take this cat to surgery and shave off its corneal sequestrum, so that was fun. And ultimately went home and lived the rest of his life, as far as we know, with no issues. So are you sensing a theme in uveitis? Realism, I'm here for it. Okay, so this dog came into the emergency room, and you can imagine that I received about 8 texts with photographs simultaneously, because WTF, that is pitch black liquid pouring out of this dog's left eye. It looks like demonic possession. It's already an Akita, so it feels plausible. So we were like, okay, this can't be good. Let's have a look. When you got in closer, you could see that there was blood inside the eye. And this discharge really was like ink pad. It was like squitting. My exam sheet from that day has like a swipe of it, and it's just pitch black. So we did a cytology of the discharge, and we're like, huh, black stuff and neutrophils. So cool. That doesn't help me at all. So we sent him home with a plan to take the eye out. We figured pouring black liquid out of your eye can't be good, even if we don't know what's going on. When he came back in, the discharge had stopped. And this dark brown proliferative tissue, what had happened was it was an intraocular melanoma that had burst through the cornea. And the aqueous humor was washing over the tumor and exfoliating all of those really dark melanocytes with the discharge. So actually, once he was sealed, the eye was visual and he was comfortable. But I was like, no, sir, no. This is what the histo looked like. So big brown mass popping out of the eyeball. We did chest rads and abdominal ultrasound, no signs of metastasis. Even though this looks really terrible, most melanocytic tumors inside dog eyes are benign. They're melanocytomas and they do not metastasize, they do not cause problems. And that ended up being the case. We submitted this to JAVMA as a what's your diagnosis a year and a half ago. So I don't know if they're just like, no way, man. Maybe one day you'll see it in JAVMA. All right. That was a good case, okay? the patient is alive, we have an answer. That's a pretty good combination. This is not. I'm gonna tell you right off the bat. This is Sadie. Sadie's an 8-year-old Cocker Spaniel. And one of those early patients in my career that left an indelible mark on my brain because there were things we could have done differently. Ultimately, I think the outcome would have been the same, but it would have been nicer. Travel well. Okay, so he was sent in for glaucoma. So a Cocker Spaniel with glaucoma, my first thought is he probably has primary glaucoma. This is going to be relatively straightforward. When we look at the bad eye, he's got a pressure of 48, so does indeed have glaucoma. The pupil is mid-range, which is strange because an inflamed eye should have a small pupil, but then a pressure of 48 should have a big pupil. So hard to figure out what was going on there. It was menace negative, really red. And it turns out that his retina was detached and smacked up against the back of the lens. And I could see these clumps of cells underneath the retina. So once the retina is detached like that, this eye is almost certainly irreversibly blind. So it's a matter of finding out what's going on. Because if the disease went to the subretinal space, then it came from the bloodstream. We need to look for a cause. So this should feel very familiar at this point, but that's kind of the idea of these cases. We start with predacetate 4 times a day. You could also do neopolydex instead. And NSAID 4 times a day. Dorzolamide, which is your safe glaucoma drug, 3 times a day. Now, because we knew this eye was irreversibly blind, because the retina was detached, we started them on latanoprost as well, to try to bring the pressure down, because we knew that eye wasn't salvageable. Okay, the owners had the money, and they wanted the answer. So we did a physical exam, and we found a mass on one of the legs that ended up being a mast cell tumor. White cells were 16,000, segs and VAMs. Chemistry, urinalysis, chest rads, abdominal radiographs, all normal. The toxo negative. Fungal screen, that's your blasto, your crypto, your histo, all negative. Tick panel, borderline Rocky Mountain spotted fever. Okay. So while we're waiting on those results, we check to see if the anti-inflammatories and the glaucoma drugs are working. The pressure stayed high. The uveitis was a little better, but the dog was behaving normally. So what's our diagnosis? What's our etiology? Is it Rocky Mountain spotted fever? Is it mast cell tumor creating a paraneoplastic syndrome? We don't know. So we thought to ourselves, let's shrink the leg mass with a little bit of chemo. I'm at a university, so of course that's what we did. Then blasting and pred, and then we'll do the leg mass excision and the eye removal at the same time, as the eye is irreversibly blind and we can't control the pressure. Now, when we gave them the vinblastine and the pred, the patient sort of crashed. Became febrile, neutropenic, and depressed. Oncology was like, oh yeah, chemo does that. And I was like, oh, okay. Responded to IV fluids, but slowly. Sorry, we got her feeling better. We took off the lid, the leg mass was completely excised. The eye was removed. The eyeball ended up on someone's desk. Yeah, it got submitted, but the ocular pathologist at the University of Georgia was at a conference. So it sat on her desk and it didn't get cut in. And I never followed up because I forgot. We sent the patient home, did really well for 2 weeks. And then the other eye got red and painful. And I went, holy shit, I never saw the path. So we found it, we cut it in. The eyeball was full of prototheca. Prototheca is an algae. It's just an environmental contaminant. The most common clinical presenting sign is diarrhea. And it's almost universally fatal. I called them to tell them their dog had prototheca, and they euthanized like a day later. So my lesson was to follow up on my path. The other thing is that if I had taken an aspirate of that eye before I submitted it for pathology and looked at it under the microscope, I would have had my answer. To have been at a higher index of suspicion when the chemo made the patient acutely febrile and neutropenic, I know. Looking back, hindsight is 20/20, right? I don't think I could have saved this dog, but they would have known what they were dealing with. So that's to me, that's the status case. Because I feel like we failed the clients. And if we had been able to figure this out before surgery, we wouldn't have put this dog through a mast cell tumor, excision, or chemo, or any of those things. But I would have had to stick a needle in the eye to figure it out. So would it have ended any differently? I don't know. But he stays on my slide set because I'm a glutton for punishment. And yeah, euthanized just a couple days later, one day later. I think about Sadie though, and I teach my residents about this dog when I say, have you followed up on every histopath you have submitted? Because you never know. So this is a nicer case. Okay, so we can let that one flush out of us. Not as traumatic for y'all as it is for me, but just a reminder to always follow up on your diagnostics. How many golden retriever enthusiasts have we in the house? Anybody? Or is there a large golden retriever? There's a large golden retriever population everywhere, right? Okay. This is a disease that is entirely or almost entirely unique to the golden at this point. Strangely, it has not popped up in the doodles yet. I know it's coming. Hula came in for a slightly red eye. And when you look from an outside light, it's hard to see what's going on. But when you backlight the eye, you can see that there's multifocal areas of adhesion and pigment on the lens surface. The pupil is not myotic. The pressure is not low. There's not a lot of flare, but there are these streaks of pigment on the lens. So this disease is called pigmentary uveitis or golden retriever uveitis. That's how breed specific it is. And it happens when these goldens are born. They've got a bunch of cysts behind their iris. And as the pupil constricts and retracts, the cysts rub spoke-like brown streaks on the lens. Ultimately, it progresses at variable rates until they get secondary glaucoma, they go blind, and we remove the eye. So identifying this disease, if it presents in one eye, the other eye is going to have it. We think that starting a nonsteroidal anti-inflammatory can preserve the eye longer, but we don't have a cure. They're working really hard at Purdue to find the genetic defect and just breed it out. It seems to trace back to the gold rush line. So I don't see nearly as much of it in Georgia as I used to see in Massachusetts, for instance. So I do think there's a high genetic association. But even if it's an incidental finding on an annual with a golden, it needs to be taken very seriously so those clients know what they're looking for. So occasionally labs and pit bulls as well. You get the progressive iris changes, the pigment on the lens capsule, the iris will become darker and darker and darker. You can get multiple iris cysts, and they frequently have this dense hemorrhagic fluid inside, and they usually end up with secondary glaucoma and blindness. So normally, when we say there's an iris cyst, that's considered completely benign. This is the one exception. So this is Hula 6 months later, and again, this screen is just terrible. But what's happened is this whole section of the lateral pupil is now stuck down. There's pigment on the lens capsule here, 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 here. So it's just proceeding apace. The eye's not red. Sorry if that gives anybody PTSD if you use the Android alarm system. That's my 5-minute warning. And then 1 year after that, the pupil is now smaller. The iris is largely stuck down. He's starting to develop secondary cataract. But I like to think because we have him on an anti-inflammatory, we're able to stretch out the inevitable. So let him preserve his vision for as long as possible. So that's my version of a good story, because he's not dead or blind. So does everyone feel better about uveitis? Ugh. What I need to do, these cases don't come to me anymore, is the 25 cases a month. I don't know, that's an arbitrary number, but the vast majority of cases that come in because they had garbage gut and the eye blew up red, and you treated them with steroid for a week and they got better. These are not the cases I see, but I know they're out there where you have some brief inflammatory episode. I've definitely got a coonhound who got uveitis as a juvenile. The guy was like, I'm not gonna pay for anything. I'm like, why did you come to see a specialist? We put him on a topical steroid. He didn't get better fast enough. So we put him on a mg per kg of pred, saying it might kill your dog. He got better, everyone was fine. So who knows? It really runs the gamut. The big thing is we've worked so hard to make you terrified of steroids that it can be difficult in the face of a disease that absolutely needs steroids to go ahead and use them. So if there's one takeaway from today, it's that when you have the three signs, red eye, small pupil, low pressure, some combination thereof, APs or hypopion, that you go ahead and reach for those steroids, because that's the difference between ending up like Luna, who was blind before I even had a chance, and having a slightly better time. All right, we're gonna take a break until 11. And those of you who come back to me will be regaled with the wild world of cat ophthalmology, which, spoiler alert, also sucks. And then we'll be done. Am I too blunt? I need to work on this. Okay, so we're gonna finish our morning with some feline ophthalmology. And I'd like to say that I come to you with bleeding edge, new modalities that have finally solved the problems innate in feline ophthalmology, but I have not. But I do have a pragmatic approach for people who won't give their cats 2 enormous horse pills twice a day for 3 weeks. So let's talk about it. What makes cats a pain in the butt? They can be very hard to examine. They are hard to treat. They respond differently to medications. You may have been told that you can't give triple antibiotic or neopolydex to a cat. Over 7 years, there have been somewhere around, I think, 60 reports of anaphylaxis after the administration of a topical antibiotic containing polymyxin or neomycin. I was originally reported in the Journal of Emergency Medicine, and then the Journal of Feline Medicine did the retrospective. Almost all of those cats received other things like vaccines, but there is this small possibility that either neomycin or polymyxin could cause anaphylaxis and death. So that's a unique, fun thing about cats. I basically treat my cats with ofloxacin usually because it's got good intracellular penetration, and God forbid anybody go into anaphylaxis. I could defend myself to the state board because there always is an alternative available. But it stinks. They're also highly sensitive to ocular preservatives. So the more drug you give and the more types of drug you give topically, the higher the chance that you will initiate allergic response to either preservative or vehicle. So we run into this problem where you treat with one thing, it gets a little better, but not good enough. So you add another thing and it maybe gets a little better. But then when you add the third thing, everything gets worse. And you can't figure out whether it's drug reaction, preservative reaction, or the underlying disease. Intraocular and periocular tumors are far more likely to be malignant. And then the gift that keeps on giving, the reason most of my cats walk in the door, herpes. Herpes virus is the bane of everyone's existence. It is ubiquitous in the cat population. And at least right now, we do not have a reliable antiviral. So what is the herp? It is a member of alpha herpes virus. It is highly species specific. Even if your client does not say it out loud, a part of them, when they hear that their cat has herpes, thinks, oh dear Lord, am I going to get herpes from my cat? Or in one very notable moment, a client who said, oh my God, did I give it to her? Which I do not have a poker face. So I was like, what have you been doing with your cat? Nope, not gonna ask. No, you did not, because it is highly species specific. It doesn't survive in the environment. So it's spread by fomites, or when they're in the sneezing, droplets. So this is what makes it really difficult to contain in a shelter environment, because it's so common. And it can have a lifelong latency. So you have the herpes as a kitten, you usually have an upper respiratory manifestation. It either clears or it goes to sleep in the trigeminal ganglion. The infection is through mucous membranes and it activates in epithelial cells. Once it's in cranial nerve 5, when it gets reactivated, it starts actively replicating and going down the nerve path through the conjunctiva to the corneal surface. And that's why you end up with conjunctivitis, because the epithelial cells die and erode. And on the cornea, for a hot second, you end up with a corneal ulcer in the shape of a nerve, because it's the cells overlying the corneal nerve that have split apart. That's your pathognomonic dendritic ulcer. Anyone who's ever taught you ophthalmology has shown you a picture of this. It lasts like 2 hours, and then it's just a geographic ulcer. So just because it's not dendritic doesn't mean it isn't hurt. Okay, so in the acute phase, herpes causes ulcers and conjunctivitis because of active viral replication causing cell lysis. There is also a form of herpetic disease called stromal keratitis, where the viral particles get into the cornea along those nerves, and then they create a chronic antigenic response. So it basically becomes an immune-mediated disease. And antivirals don't touch that because there's no active viral replication. Stromal keratitis or chronic herpetic keratitis usually doesn't have ulcers. So this is your classic kitty, right? Oh, we just adopted him and his right eye is a little squinty, his third eyelid is a little up, and there's anything from watery to mucoid discharge. Okay. You should run through your mind the potential differentials for herpes, even though it's almost always herpes. And those are chlamydia, chlamydophila, calicivirus, which can have conjunctivitis, but almost always has the oral lesions at the same time, or mycoplasma. So how do I differentiate these? There's going to be a few helpful hints. There have been a lot of studies, but they're all over the world and they're really weird sample sizes. So if you're like, why, Dr. Myrna, are you telling me about Rio de Janeiro, Korea, and Florida? Because that's what's in the literature. And so depending on where you are, Oregon, what's happening with the mycoplasma, folks? I don't know. Same with Spain. There's definitely prevalence of these other conjunctivitis causers that are in the mix. So here's your clinical signs. This comes from a, I don't know why I don't have the reference down at the bottom, but I think it's the Journal of Feline Medicine and it's a summary paper. And herpes, in the active juvenile form, you've got the punky feeling kitten who's sneezing with discharge. There's never going to be oral ulceration from herpes. They may be a little drooly, and that's probably from ocular discharge going into the mouth. But their primary signs are ocular discharge, conjunctivitis, and it's the only one that causes corneal ulcers. Okay, so if there's corneal ulcers, it's almost certainly herpes. Other than that, it gets a little vague. Your calici, it's really about the mouth lesions in combination with the ocular lesions. And your chlamydia, you get the conjunctivitis, but there's never a corneal component. In my experience, chlamydia and mycoplasma are bigger problems in cattery environments. They almost always present bilateral, and there's multiple cats who break with it. And they respond best to systemic treatment with doxycycline. So you may find ophthalmologists who just do a course of doxy as routine for a cat with conjunctivitis. I think killing cats is hard, so I don't do that until after they failed a normal course of treatment. So I don't know how many of you work with shelters. You may talk with shelters or rescues. How can we possibly reduce ocular and upper respiratory disease in shelters or when you're bringing a new cat in? And the short answer is, we don't know, right? We know that stress exacerbates herpes and triggers outbreaks. The real question is, let's get Zen here. What is it? What is stress to a cat? Is it a dog sitting next to them? Maybe. I had one cat who broke with herpes every time he saw the owner's suitcases because they knew that person was going out of town. They freaked out. So how can you possibly manage stress, right? We pretty much off the feel away train, or that may be a UGA thing. So we don't know. Do you test every cat for herpes? I don't. Do you give prophylactic treatment for new arrivals? These are all good questions. So, the biggest upper respiratory risk for adult cats being brought in is the number of times they're moved. So do they go to your house and then the bathroom and then they're brought to another house or something like that? And then how big is the space that they're in? So we know that if we can keep them in the same spot in a relatively roomy environment, that's going to reduce the spread. And if we can keep our cats 6 feet apart, after coronavirus, we all know this one, right? Then the droplets shouldn't be able to spread from one cat to the other. My favorite one is they found that you should not keep them in total isolation, that playing with the cat, even when they have upper respiratory disease, shorten the duration of their infection. So probably it reduces stress and improves relative joy. Obviously, there are plenty of cats who don't want to be played with, but the interaction increased secretory IgA, which is actually why I'm trying to make you all laugh today, because that also increases secretory IgA, and it will prevent your herpetic outbreaks. No, wait, something is wrong there. So the control cats that weren't touched were more likely to develop upper respiratory infections. So don't stick them in a room like a, old school orphanage where they kept the babies in isolation. It turns out you need to be touched to develop. Touch your little kids. This is getting weird. Okay, so that initial form of herpes, your worst case scenario, severe upper respiratory signs. They end up with secondary infections. They can get infections under their eyelids before the eyelids open. So that's when you end up with these little pus balls where eyes should be. Obviously, if they get chest infections, antibiotics could help. If they get secondary bacterial infections on top of the herpetic infections, then topical antibiotics can help as well. Mild cases should get better in 2 weeks. So in general, if I institute a therapy and the patient gets better in 2 weeks, I assume that the patient did that, not me. And a lot of times you may get this impression in your practice that I put all these cats on terramycin or erythro or Oflox and they get better in a couple of weeks and I'm really doing good, when in reality you might be doing nothing. Just a little humbling for you here today. This cat was very, very sick, and obviously.
What systemic antibiotic would you choose for this kitten?
For this kitten, I'm lucky because I have internists. They usually do Lavomox or amoxicillin. I assume I'm only doing systemic antibiotics for chest disease, if that's what I'm worried about.
Yeah.
Now, you can imagine when you have active viral replication before your eyes open, you have eroded conjunctiva, deepithelialized conjunctiva, that's swollen and pressed up against deepithelialized cornea. And what's going to happen is you will get permanent adhesions of the conjunctiva to the corneal surface. In really bad situations, not only will the third eyelid be elevated and stuck to the cornea, but the whole corneal surface may be covered. Now, logic says I just break that down and yay. But reality is that it is very, very hard to break down these adhesions without them happening again. There was a recent good paper that showed you can break down the adhesion with the third eyelid and then tack the third eyelid to the skin to keep it down. And they had some success with fixing this symblepharon. But the big thing that I would have you know is that If you see these adhesions or it looks like conjunctiva has grown across the surface of the eye, this is not active disease. This is the footprint of previous disease. And if the eye is partially closed or the third eyelid is elevated, or they sometimes have adhesions that block their nasolacrimal duct, this cat is never going to be normal. It's always going to be a little squinty. It's always going to look a little pink. It's always going to have discharge. So you've got to learn what's active disease and what's previous injury. And that can be a little challenging as well. But if you see enough cats, you'll definitely see ones where their eyes are all stuck together at various levels. Only once did I have a cat whose conjunctiva swelled up over its cornea and adhered, but his eyeball was normal underneath. And we were able, this poor cat was 2 years old, and we were able to cut open the conjunctiva and it was like, oh, there's an eyeball under there. Not usually how that works, but obviously I will be telling people about it forever because I sent videos to everyone I knew. And they're like, what's wrong with you? I'm having dinner. But it's better than maggots, okay? Like, some people disagree. They think eyeballs are the worst thing that could possibly be. In the latent form or the recrudescent form of herpes, so after the kitten stage, what's most likely to happen, say you introduce a new cat to your household and your existing cat breaks with a squinty eye, is they'll have some combination, the reactivated virus travels down the ophthalmic nerve, they end up with conjunctivitis, corneal ulceration, some combination thereof. Here's a beautiful dendritic ulcer, which I told you almost never happens. And then the ones that have recurrent, repeated bouts of herpetic disease are the ones that end up with stromal keratitis, where you have this immune-mediated disease. And that one's really frustrating because I just told you topical steroids will reawaken the herpes, but stromal keratitis patients often need topical steroids. It's just one of the many reasons treating cats is a pain in the booty. Secondary bacterial infections, relatively uncommon, but possible. And that's when you're assessing an ulcer in a cat, you're still going to go through those 3 stages we talked about this morning. You're going to say, is it superficial or deep? If it's deep, you're going to assume bacterial infection. Is it infected or not? Well, there's bacterial infection, but then there's also a presumptive herpes infection that's always on the table. And then is there an underlying condition that's keeping it from healing? Again, the first 3 parts of that list in a cat are herpes, herpes, and herpes. So it's still a relatively similar approach. Okay, here is a rose bengal stain. I don't know if anyone's still got rose bengal on their shelf. We have some weird Japanese rose bengal that's 5 years out of date, and we hide it from the pharmacy police when they come to throw away all the expired stuff. One day, someone's going to write a letter to the University of Georgia administration and be like, you will not believe the things this girl is saying. So here are the dendritic lesions. They're showing up sort of bright pink, pathognomonic in the shape of the nerve. You wouldn't ever, when you see a dendritic ulcer, you never have to do other diagnostics. There's no other underlying etiology that gives you a dendritic shape. Okay. This is more typical, as I said, just mild conjunctivitis, elevated third eye. Okay. So what do we have for antivirals? The commercially available product is Virofin, which is trifluridine. This is only effective during active replication. It's still expensive, but what's worse is that you're supposed to do it 4 to 6 times a day for the first 3 days, ideally 6 times a day. And if stress is a big part of herpetic outbreaks, 6 times a day treatment is not gonna help with that for most cats. So I don't use it a whole lot, but it's the FDA approved one that we have. Everything else is compounded. So depending on what era you went through vet school or who your local ophthalmologist is, you may be a big fan of idoxuridine, vidarabine, or cidofovir. Idox has very few side effects. Still is supposed to be started 4 times a day. Same with vidarabine. These are usually available as ointments. Cidofovir has one selling point, but it's a big one. You only treat twice a day. It is very expensive, however, now. In terms of the most effective antiviral with the most literature behind it, is by far and away oral famciclovir. That's your Famvir. And after many years of going back and forth, for at least 4 years straight, David Maggs at UC Davis has said 90 mg per kg twice a day for 3 full weeks is the appropriate dose. You don't wean it, you don't do the low dose, this is what you do. These pills are huge, right? They're big chunk and horse pills, which can be hard. There was a study on compounded famciclovir in liquid form, and it showed the concentration was all over the place. Because this is not a drug that goes into solution super well, so use at your own risk. And it has to be famciclovir, right? Valciclovir kills cats. So that's an absolute no. Acyclovir has a lot of risks as well. So it's only FAM. These are not antivirals that you can turn between or switch between. Okay. Are they any good in a shelter environment? Long story short, no. Even if you put a bunch of cats on famciclovir, when you move them into a high stress environment, it doesn't do anything to reduce the outbreaks. What about lysine? Is anybody on the lysine train? So L-lysine is an amino acid. It's a nutraceutical, so it's not regulated by the FDA. You can buy it over the counter anywhere. The idea is that it antagonizes the availability of arginine, but it is safe for cats up to 500 milligrams twice daily. The initial sort of profound studies came out, showed that it reduced the severity of outbreaks and it increased the time between outbreaks. Since then, we have had, you would think a shelter would be the optimal environment to put L-lysine in the food to reduce the severity of outbreaks. The half of the shelter that got the L-lysine had worse outbreaks than the ones that didn't get it at all. We don't know how much of it they ate. And then there was another study that showed that the concentration of L-lysine you would need to achieve to affect viral replication could not be obtained with the oral doses that we give. So what do I do about L-lysine? Well, it's non-prescription, it's totally safe. There is probably a very small percentage of cats for whom it makes a substantial difference. It is a great way to give a client who's feeling helpless something to do. But if it is stressful in any way to administer that L-lysine to a cat, then don't do it because the negative is probably outweighing the positive. As not being much of a vitamin gal myself, I don't usually prescribe it. My residents still prescribe it somewhat regularly. Inevitably, if you find a form that your cat likes, like the maple syrup gel, they will stop liking it as soon as you buy a family pack. You can just buy the pills and grind them up and put it in tuna water. That might work for a couple of months. You know, cats be catting. But after I saw this study, I was like, well, what is real in this world? So if the majority of corneal ulcers and conjunctivitis in the cat is herpetic, do we really need antibiotics? Right? We know that viral infection can make mucopurulent discharge without concurrent bacterial infection. Herpes, chlamydia, mycoplasma, bordetella does not respond to triple. So if you're choosing a prophylactic antibiotic in a cat, don't use triple. A, there's a chance for anaphylaxis. B, it won't work against the most common infectious diseases. We do know, however, that ointments can really help with healing in cats because their tear film's all screwy from their conjunctivitis. So it's possible that just applying any ointment would make them feel better. So here's what I do. When I start with a cat with just conjunctivitis, no ulcers, I give them either nothing, send them home for 2 weeks to be alone and think about what they've done, with an email update, or I send them home with a preservative-free artificial tear or a hyaluronic acid artificial tear to soothe them and help them get over the hump. If they have a corneal ulcer that has a potential for secondary infection, then I'm going to send them home with either erythromycin, terramycin, or ofloxacin. I apologize that that's not on the screen. Ofloxacin works well against chlamydia and mycoplasma, and it's a good broad spectrum antibiotic to prevent secondary infection. So that's usually how I approach first-time patients with corneal ulcers or conjunctivitis. One study took shelter cats and either gave them terramycin or cidofovir, and there was no correlation between being herpes positive, mycoplasma positive, or what drug they were given. So again, everything is meaningless. We exist in an existential void. What is the purpose of life? That's what I really want to end with on this morning about ophthalmology is what is our place in the universe? It's fun. What about interferons? I've had to go to WikiHow to find a diagram of someone administering interferons because that's how out of date it is. If no one has been to WikiHow and you need some laughs, there are 3 articles I recommend for you. What to do if my dog is choking. Huge fan. How do I treat my cat's ocular discharge? Because there is a diagram that literally looks like they're slicing off the upper lid with a pair of kitchen scissors. Chef's kiss. And then what do I do if my hamster is blind? Okay. So these are 3 great options for you. Interferons are cytokines, they immunomodulate. Interferon alpha is supposed to stop cell-to-cell spread of viruses. This goes in and out of fashion. You give it by mouth and it will reduce clinical signs, but it's very unstable when it's thawed. So it seems like probably the first dose works, but if you send it home with them, not sure what subsequent doses work. When you're dealing with a disease process where there's no treatment that's reliable, there's always going to be a small population that responds to something. So that's why interferon alpha stays in the mix. So if you ever hear about that. Same with lactoferrin. It's an iron binding glycoprotein that's found in the milk and other fluids, but they went with lactoferrin for obvious reasons. It has an antiviral effect in vitro, but no one's figured out what the proper dose for a cat would be. If you Google it, people have doses. I just don't know if they work. So What about steroids? Don't do that. Immunosuppression will definitely exacerbate viral infection. So don't do that. The only time we get to use that are for the stromal keratitis. So, see, this is the whole thing. I just spent an hour and a half telling you that you shouldn't be afraid of steroids. And then I just told you, don't ever put steroids on a cat. You know what's going to happen. So if you think you have herpes virus keratitis, should you do the diagnostics? I don't. So there's that upper respiratory panel now that you can do that does several upper respiratory diseases. I could see running that panel if your patient is actively sneezing. But for a cat with a corneal ulcer and conjunctivitis, if it comes back positive for herpes, that's great. If it comes back negative, I'm just not going to believe it. So to me, it's not a good use of the client's money. And not everyone feels the same way. But if you thought I was a minimalist before, when it comes to cats, the absolute least I can do will probably have the best clinical outcome in terms of preserving the client-patient relationship. And half the time, it's about helping your clients come to the understanding that their cat is never going to be 100% normal. Because if they've got herpetic conjunctivitis, they're probably intermittently always going to be a little squinty, always a little gooey on that side. And unless there's a dramatic uptick in pain or discharge, it's probably more beneficial to the cat to just leave them be with that mild amount of irritation than to put them through a bunch of drugs that could cause problems. The clients that really stress me out are the ones who want it perfect. Because when it comes to cats and eyes with herpes, you almost never achieve perfect. And that's just true. I've got 2 cats at home. I have way too many cats. The one with no eyes, I solved his herpes permanently. He was born with microphthalmos. It's not other things. So obviously that's one solution for all cats with herpetic keratitis is bilateral enucleation. But the other, I have 2 who squint about every other month. One in the right eye, one in the left eye. And my ex-wife would be like, why can't you fix them? You're an ophthalmologist. And I was like, because herpes. Anyway, she's my ex-wife. Okay, moving on. So we're very friendly. She's taking care of everybody at home right now. So here are all of the available antiviral drugs that are recommended. This is the ABCD guidelines for feline herpes infection. It's a review article. You can Google for it. You can cut it out and paste it on a cabinet somewhere where no one will read it. And then you'll get a student who's fresh out of school and it's like, this is wildly out of date. But it's still fun. But it does go through everything. It tells you about the efficacy in vitro, in vivo, whether they're published studies, so on and so forth. Basically, if you were to summarize the whole thing, is famciclovir works, everything else is eh. Okay, questions about herpes? All right, my pragmatic, low-key approach remains. Conjunctivitis, ignore it or a lubricant, ulcers, ofloxacin, and a couple of weeks. And then if it doesn't get better, then I try topical antiviral. And if it doesn't get better in 2 weeks, then I commit them to the famciclovir by mouth. So that's how I progress. Corneal sequestrum. Has everyone seen a corneal sequestrum? Maybe? This is a weird cat disease. And it happens in coordination with chronic superficial non-healing ulcers. Now, what we don't know is if non-healing ulcers cause sequestrum or if sequestrums keep superficial ulcers from healing. But like a bony sequestrum, it's a devitalized piece of tissue, but instead of being sequestered, it's on the surface of the eye. So I don't love the terminology here. It starts as a tea-stained light brown spot, and then it will proceed to a scab-like black thing. And we know that it's associated with herpes virus, but in Persians, Hinnies, and Burmese, the brachycephalics, they get recurrent sequestra in the center of their corneas, which we assume is due to exposure. Okay. The diagnosis is relatively straightforward. It's clinical appearance. If there's something that looks like a black scab on the surface of the eye, that's what it is. So in this photo, we can't see the white of the eye, so that's the iris. That's the pupil. And this out of focus blob is the corneal sequestrum. So it's dead, black cornea. The body is growing blood vessels underneath it to expel it, to shed it off. They're usually central. They're often associated with a corneal ulcer. The amount of inflammation is very variable. The amount of pain is very variable. So one of my new favorite things is to look at smush-faced cats on TikTok and see how many of them have corneal sequestrums. This replaces my previous game of watching Facebook videos and saying, is it cute or is it a neurologic disorder? Which is also a lot of fun. This puppy is so excited to see his parents, he faints. No, that's not what puppies do. Okay, so here's your Wilford Brimley cat. He's here to talk about the beatus. And his left eye is squinting. And what you can see is that there's this like tea-stained area with a darker spot in the middle. If you look at these under histopathology, the cornea, it kind of looks like those indolent ulcers, but instead of that thickened area of stroma picking up the H&E stain and being pink, it's brown-black. And you wouldn't think this, but there have been at least 4 studies trying to figure out what this color is. It's not melanocytes. There's not even consensus that it's melanin. It's very confusing. So we really don't know why it turns brown. Okay, so this is the diffuse form. So this cat has had a corneal ulcer for a month. The blood vessels have grown in. The conjunctiva is edematous. And then it has this large light brown staining area. So to me, chronic non-healing ulcers in a cat are on the way to sequestrum most of the time. And the other thing that cats like to do is they squint so hard when they have chronic ulcers is that they cause secondary entropion. And unlike dogs, once they've managed to roll their lids in, they usually need surgery. So one neat trick, this is my clickbait for the morning, one neat trick ophthalmologists don't want you to know about is if you can catch a non-healing ulcer that's starting to turn brown early enough, you can sometimes put contact lenses on, and whatever the brown stuff is will leach into the contact lens. It's kind of like magic. And every now and again, that fixes them. So don't ask me what's going on, I don't know. But it's really fun because you take the contact lens out, it's literally brown. You're like, oh, cool. So what comes first is there's a study that shows if you do grid keratotomies on cats, they're more likely to develop sequestrum. My thought has always been, if there's been an ulcer in a cat long enough to make you want to do a grid, they were probably about to develop a sequestrum anyway. But who knows? We know that in this early stage, sometimes, the other thing you can do is you can burr the brown away. So if you remember that diamond burr that I showed you for the non-healing ulcers, that was the little handheld diamond dusted Dremel. If you sedate a cat, you can literally burr off the brown region, and some of them will heal. Combine that with the contact lens, you've got magic on magic. Trademark Myrna. All right, once they get to this stage where they're very discreet and they're deeply pigmented and they're starting to look like a plaque, and every ounce of your brain is like grab it with forceps. You can, but it's not gonna work. I'm just here to tell you, every time I'm like, it's about to peel off, all I have to do is grab it, I'm wrong. So you have to let it come off on its own. You have two options here. So you can either surgically send it away to have it surgically excised. And this is a tough thing because I don't know how much, if any, healthy cornea is under that thing, because it's pitch black and I can't see through it. So surgery might be really short and easy, or it might involve a corneal transplant. I don't know. So then I ended up getting some ridiculous quote, like 1,400 to 35,000. And people, not 35,000, 3,500. And the clients are like, I don't know if I can sign on to that. I'm like, I get you. If you leave them alone, they will slough off eventually. There are three drawbacks to this approach. One, it might take 2 months or 2 years. Two, they're often intermittently ulcerated, so that is a lot of discomfort and the potential for secondary infection to set in. And three, when they slough off, they might not slough off in their entirety, leaving sequestration behind. That being said, natural healing gives you your best visual outcome and is the least invasive. So here's one that's sloughed off on its own. So thanks a lot. There's infection and it left a piece behind. So we went ahead and did a corneal transplant. I've also had them slough off in the eye perforate. So that's super fun. This is a corneal conjunctival transposition. It's basically a sliding corneal advancement flap. You undermine the healthy cornea and the attached conjunctiva, and you just slide it into the others. Easy, right? Y'all can do this. Just kidding. Don't do this. And it looks really nice. You can also cut off the sequestrum if it's not infected, and you can put decellularized pig small intestinal submucosa on it, and they'll usually heal. So there are a lot of options. If you're going the conservative route, then you have to decide if you keep them on an antibiotic constantly because of their risk for ulceration, or if you have the clients monitor comfort, then you're going to check in on them every couple of months. Once all that money and frustration sets in, they may have wished they went to surgery. I don't know. Honestly, if it happened to my cat, I'd be 50-50 on whether to take him to surgery or let it resolve itself naturally. If I had a Persian, which I'm a crazy cat lady, but I'm not that crazy yet, I would probably take him to surgery. So here is just a completely unrealistic example of a cat's corneal healing. We have the sequestrum, we cut it out. We did a partial thickness frozen corneal transplant, and then it looks like almost nothing happened. I never get away with that in a dog, but cats just heal super well. So, I mean, this is what all of my cases look like because I'm the best. All right. Questions about sequestrums? So questions, if you will. What's up?
Would collecting that horse serum and using serum drops, would that be helpful in a long-term basis if they're
Right.
going medical?
So the question is, if you're doing conservative management, would adding serum help? It would reduce the chances of melting. I probably wouldn't add it in unless I had a high suspicion of a secondary infection. And it's another drop to give your cat, which may already be difficult. So I've never thought about it. It's a good way to get them coming back in the hospital, right?
If you
But
could
so
store-
far, we don't have any evidence that the component parts would help the disease particular, only if it got a secondary infection. Right. So Yes.
Can we get sequestrians in the anterior chamber?
Okay, so the question is, can you get a sequestrum in the anterior chamber? You cannot.
Okay.
Did you see something like that?
I had a horse that had, for 3 days, was getting much better. All of a sudden, it grew up, became a melting ulcer. By a fungal, I actually had an ophthalmologist look at it. They said, no, they can give us multiple foreign bodies.
Ooh,
And so
did one of them stay in the anterior chamber?
I don't know. And so the eye calmed down, the eye is like completely clear, but there's a black squiggle behind, like right behind the.
Okay, that's probably a bit of iris or corpora that's stuck to it. But
I mean, it is jet black, and it doesn't seem like it, there's not like a sneaky.
it may have ripped off. Just a thought.
Oh,
Yeah.
yes, thank you.
Yeah. So this is another reason we present for squinty eye with discharge. So if you had no idea what this was and you saw this sort of raised proliferative plaque-like stuff, hopefully your gut would say, hey, those are white cells where they're not supposed to be. Dr. Myrna told me to do cytologies on these. And all you need is one cell on your slide that's an eosinophil, and that confirms your diagnosis. So this is the cat's autoimmune keratitis. It's correlate to, say, Panis, where the body attacks the cornea for reasons we don't know. Now, we know when cats have autoimmune disease, they're just all about the eosinophils, right? Oh, I'm attacking your mouth, eosinophilic stomatitis. Oh, you have weird skin things, eosinophilic granuloma complex. Oh, I hate my own eye all of a sudden, it's eosinophilic keratitis. That doesn't mean that those diseases are linked. I just think it's a weird cat thing. For my horse people, since I have a couple in the audience, this is also a disease that horses get. And the horse one is way more frustrating than the cat one in general. But you can come talk about it after if you want to share a beer and cry about horse eye disease, because I always do. Okay, so I say cats only, but that's because this is a small animal lecture. Cats and horses. 76% of cats with eosinophilic keratitis are positive for herpes, but maybe 80% of all cats are positive for herpes, so we're not sure what the link is. UC Davis thinks there's a strong link, so they will always treat eosinophilic keratitis in a cat with antivirals and anti-inflammatories at the same time. You do not need a ton of eosinophils. If there's one on the slide, that's one too many. They are not supposed to be there. Same with horses, just one little mast cell with its beautiful granules. So we have a bunch of epithelial cells, and then we have a couple of these EOs just chilling out. That confirms your diagnosis. And that tells you this is immune mediated, and the foundation of immune mediated disease treatment is immunosuppression, because you can, so now you see the problem we're going to find ourselves in. This eye is best treated with topical steroid, which is going to be your prednisolone acetate, which will reduce the eosinophilic plaques, but it could cause local immunosuppression and reawaken the herpes, which leads to ulceration, which means you have to stop the steroid, which means the eosinophilic keratitis is going to come back, and you see where we end up. So that's why at Davis, they'll start these all on 3 weeks of phencyclovir together with the topical predacetate. I will do almost anything in my power to avoid killing cats, as we well established. So I will start them on predacetate alone. And I will say it should only look more comfortable. If it's suddenly squinting, you come back to me, I'll add in an antiviral and an antibiotic, and we'll start playing the game. Because it's an autoimmune disease, there's not necessarily a cure. Some will have one outbreak and that's it for them. Some cats will have a seasonal problem. Some cats need daily or 3 times a week maintenance. keep them from happening. When it's left to get completely out of control, the entire cornea can vascularize. This cat is functionally blind. He looks like he has cancer, but it's the blobs of infiltrate that give you the hint of what you're dealing with. So that's EK. In the olden days, you would give them, oh my gosh, my brain is farting. It's the estrogen. All right, we're gonna stop that. Pardon?
Yes.
Yes. When you maybe would kill their bone marrow, but you would definitely get rid of their eosinophilic keratitis, right? So it was pretty cool. We tried a topical version of gestrol acetate, and it doesn't work nearly as well as the systemic, but you may hear about that. Some of these cats I can transition to a more chill immunomodulator for chronic control, like cyclosporin or tacrolimus. A lot of cats will be irritated by the vehicles in those, like corn oil or olive oil. So most cats that I put on cyclosporin or tacro, I have them make it in the aqueous, so it's less irritating. Tacro goes into aqueous better, for what it's worth. So this is starting to feel like a grab bag, and we're almost done. So in fact, we should be done, but I'm going to do a few more. Iris melanosis. It exists on a continuum between a freckle and cancer. When does it change? Nobody knows. So when do you take eyes out versus when do you take a picture and watch? If the lesions are black, velvety, raised, if they distort the shape of the pupil, those are reasons I will take the eye out. If they are rapidly changing and the cat is young, I will take the eye out. If a cat is geriatric to start with, it will probably die of something other than its iris melanoma. These can metastasize, they go to the liver and the lungs. They seem to be slow to do so. Nobody knows. If it's only in one eye, this is relatively straightforward. You can always take the eye out. If both eyes are affected, and you have two comfortable visual eyes in a healthy cat, very hard to justify taking both of the eyes out. This one, it's all out at the edges, so there's a risk it's going to go to the bloodstream. We also have a chance to potentially laser them. This is just not a part of the body that's easy to biopsy, with it being an eyeball and everything. People have done it, but it doesn't seem to change the ultimate outcome. Here's one we waited too long, and now the melanoma is busting through the iris or through the sclera. So it's probably spread elsewhere in the body. So I don't know this one yet. And we just did a journal club about it, and I feel like I know less than when I started. I am conservative, so I usually take a photo, or I do what I call an iPhone biopsy, where I ask them if they have pictures from like a year ago that are close up on their cat. These days, everybody does. You take a look and see if the lesion was there before. Rapid growth or hyperpigmentation that starts to look genuinely black are the things that push me over the edge. This is a fun one because it's a very small area. It's right in the corner. It's not distorting the pupil, but it's very dark. I took a photo, had them come back. I'm more worried about this one than this one, where the whole iris is turning sort of light brown. But this was much scarier to the client. It used to be completely yellow, and here they are. And just, I'll leave you with this one thing that can look really terrifying. Has anyone seen iridociliary cysts in a cat. They are pitch black. And they can either extend like terrifying balloons from the backside